So in step one class, we've kind of been getting through renal physiology, and everyone signed up for both of the courses. It's actually perfect for them to kind of have overlap between the two. Now, when you get to renal CK, you kind of see the same pathology topics show up all over again. There's not really anything major that's new here as opposed to step one. So if we go to renal step one, right, so they don't really have a step one renal outline like this. But in step one renal pathology, you first start off with nephrotic versus nephrotic versus nephritic syndrome. You go into all your different kidney stones, memorizing them. Then you go into actual damage that occurs inside the kidney, whether due to renal cell carcinoma, huge topic, or other types of cancers that are relevant to the renal system. That includes the bladder. Huge topic about urinary incontinence and all the different things that occur with that, right? And then you top it off with pyelonephritis, acute kidney injury, and in the very end, your huge other last topic, which are best spoken about as just AIN, ATN, RPN, and then of course in the very last page you just have your renal cyst disorders, which of course are often answer choices and things people are not very confident with. So you see all the same things here as well, nothing much that's brand new. Two of the probably most notoriously disturbing topics are probably the acid-base disorders. A lot of students struggle with that till the very last day, and then of course urinary incontinence, which can also often be very confusing until you've mastered it in such a way that you don't really need the book in front of you to explain it. So that being said, first thing here is actually talking about electrolyte disorders. Now, electrolyte disorders, it's so significant for them. They've actually listed out the page number for each one of these things individually. And questions about electrolyte disorders is very similar to step one nutrition, where you would get vitamin deficiency questions. For each one of these, from your mind without really needing the book, you should be able to list out the number one things that can cause hypernatremia, and of course how it would present. Same thing for each one of these other ones, and what the biggest problem would be for each one of these issues. You should have a fairly good idea, and that's the first thing we're going to wrap up today. We're going to look at electrolyte disorders, starting off with hypernatremia, serum sodium that's more than 145. Normal sodium levels and normal electrolyte levels in general is something that you want to memorize. You should have this memorized, not something you want to really depend on the table for. Yeah, you'll have the table there on your test, but the amount of time it takes to go and compare each number takes away valuable seconds from you. You want to memorize normal sodium 135 to 145, normal potassium 3.5 to 5.0, stuff like that. You just want to have it in your mind, and it's not something you sit there and repeatedly memorize. It's something that sticks to you after you've done your due diligence of doing repeated practice questions. So when serum sodium is more than 145, that's officially hypernatremia, usually caused by free water loss rather than actual sodium gain, right? And this was actually in a very nice step one question, where there was a question of asking about a guy who had a very heavy salty food intake on a certain day, yet his serum sodium was still at a normal level. Now keep in mind, the difference between percentages and dollar values, right? So I also run a YouTube channel where I teach stocks, right? Now if you buy something, and let's say you bought something and it was worth $10, and you only bought $10 of it, so basically you just bought just one share of that $10 stock, and it goes up to $20, right? So then how much did you make? Well, you made a profit of plus $10. But that's not what you should really be talking about. What you should be talking about is you made a profit of a plus 100%, right? And this is often something that a lot of companies do to obviously make themselves look better than they actually are, right? Because they're not lying. This is a 100% increase, but it was really just a $10 profit. Either way, though, the best way to look at it, even though it sounds fishy, or it sounds like they're deceiving you, they're actually not. They're not lying, and they're not deceiving you. They're telling you that they only bought $10 of it and it became $20 and they made 100% profit. It's true. Had you bought more, you would have also made 100% profit, and your profit would be different dollar value. So it's actually correct to tell someone that the profit was 100%, because this would apply to every single person. So for example, if another person bought $50 of this, that means they bought 5 shares of this, right? They bought 5 shares of this $10 stock. They put in $50, and then their money would become $100. That would, once again, successfully mean that they made a 100% increase, not that they made a $10 increase, right? They actually made a $50 increase. So what the point of this is to focus on this over here, right? Saying 145 is not equal to the dollar value. 145 is more so a ratio. What that means is that this is milliequivalents per liter. So there's two ways you could change this 145. Right? This 145 is milliequivalents per liter. So there's two ways you could change that. This is 145 milliequivalents of sodium per 1 liter. Right? And this is 1 liter of basically serum concentration. So since this is a concentration, there's two ways to change the sodium. Either you increase the amount of sodium that's in every 1 liter, or you lower or increase this liter amount. Right? If this becomes bigger, maybe the person has water retention, and their serum concentration of sodium would have to be lower in that case, right? Because if you make the liter bigger, imagine this becomes 2, then now this is basically 145 divided by 2, which is 73 roughly. 73 milliequivalents per liter, right? Milliequivalents per liter. I'm just going to write M over L. So you see how this number 145 became 73 really quickly as soon as the person's water retention literally doubled. Now it's very rare for water retention to double in a person, but it can increase, right? So it would increase from whatever it was before to a higher number, and as this denominator would get bigger, the sodium concentration would get lower. That is known as a dilutional effect, right? You've probably seen that as an answer choice. The salt is just getting diluted. That's all that's happening. But less common is for actual sodium gain to increase this. That doesn't happen. Your body is full of space to actually divert that sodium, and you have plenty of hormones that are around to kind of control your sodium concentration the best they can. But all your hormones can really only control sodium concentration that's based off of sodium gain, not sodium concentration that's really based off of water loss, right? So for example, if you're dehydrated, right? If you're dehydrated, then what would happen in that case scenario? Well, that would be the opposite of the previous example I gave. So instead of 145 over 1, you would basically change this 1 into like a 0.5, right? So now you lost your water, right? So then this would be the opposite of a dilution. This would actually double your sodium concentration from 145 to 290. Now again, these are extreme examples. Your water concentration won't go from 1 to a half or a 2, but it would go in that direction, right? It would go towards a half, or it would go towards 2. And as it goes towards those numbers, these are some of the bad concentrations it would go towards. And so this is something that you can't really do anything about. What are you going to do when you have water loss? Obviously, if you're dehydrated, you must not have any water to drink, and you can't form new water, right? So this part becomes a problem, but usually caused by free water loss. This you can't do anything about. So when you lost water, your sodium concentration will go up, and the only way to fix that is to drink water, right? But if you have sodium gain because you decided to just eat a bunch of salty food, that you can control. That you can definitely control, and that's something that will not cause this number to be altered heavily, right? And that's because of the effects of aldosterone and ADH working together. Mainly ADH working together, aldosterone not working, right? Aldosterone is actually supposed to do salt retention. It'll stop working so that you don't have this number get bigger. So those are some key things. And then of course all electrolyte management is based off of certain hormones working, aldosterone, ADH, depending on what other comorbidities the person may have, insulin, BNP, stuff like that. They all have effects on electrolytes. And then derangements in electrolytes give away what's happening in acid-base disorders, right? So this is why electrolyte disturbance is going to lead to acid-base disorder topic, and we're going to make sure we understand that connection. Presents with thirst because of the hypertonicity, neurologic symptoms including altered mental status, weakness, focal neurological deficits, and seizures. for the look at this figure for the hypernatremia diagnosis algorithm. Diagnosis is based on the urine osmolality and urine sodium. So remember, we're always replacing this word osmolality with urine solute concentration, right? So urine solute concentration and urine sodium. Those are some of the things you look at for a diagnosis. So let's look at this diagnostic table they have here, right? This person presents with hypernatremia. First thing you do is check their urine, okay? If they have urine osmolality that's high, that means that not only do they have high sodium, their urine sodium concentration is also high. So they're actually peeing out all that extra sodium they're retaining, right? Urine osmolality is high solute concentration. So then you check for what's actually causing it. Is it an extra renal loss like vomiting, diarrhea, nasogastric tube, or insensible losses? Or is it because of a sodium gain like someone who may have gotten hypertonic saline? Not a sodium gain from food though, right? Depending on what's happening, you can figure out what the real cause was, and it would be based off of what's in the question. This bottom part is the part you probably have to study a little more. The top part is pretty commonsensical stuff from endocrine step 1 about diabetes insipidus, right? So anytime a person has hypernatremia and their urine osmolality is also high, that means that all that hypernatremia is actually pouring out in the urine. The urine solute concentration is also high. So now you need to figure out what's happening. And that's all this is really about. For this case scenario, this is pretty easy. If urine osmolality is low, then urine solute concentration is low. If urine solute concentration is low, then you need to understand why, right? Why, if you're a hypernatremic patient, a person with too much sodium, then you should be peeing out the sodium, right? So why is your urine solute concentration so low? Why are you the only way your urine solute concentration can be really low is you must have made the kilogram part big, which is water. So you must be urinating a lot of water, right? This is basically, the bottom part is very concentrated urine, right? Concentrated urine means that you don't urinate any water. This is very dilute urine, right? This is why it's got a very low solute concentration. It's very diluted with water. So now you need to figure out why. If there's a rise in urine osmolality with decompression following water restriction, then it must be central DI. Basically, you do the water restriction test from step 1 endocrine. You tell these people to stop drinking water, right? Anytime someone has very dilute urination, it makes sense that the first thing I'm going to tell that person to do is to stop drinking water. Now, if they stop drinking water and then correctly their urine actually becomes normal osmolarity, then you start thinking, oh, there's definitely something wrong in the central part, right? It's also possible that it's psychogenic polydipsia. So there's a third scenario here as well, which is the PP, basically psychogenic polydipsia, which is a person that's just drinking a lot of water. These people often tend to also have, in practice questions, some kind of psychotic illness like schizophrenia or any psychosis really. And the problem is that a lot of antipsychotics and even mood stabilizer medications like lithium can cause people to become very thirsty. And in these people also, when they stop drinking water, then just like a normal individual, when you stop drinking water, your urine stops being diluted, right? So rise in urine osmolality with decompression following water restriction. This is central DI. If you do the water restriction test and there's no rise in urine osmolality with decompression, then that basically means that you're not seeing any ADH activity. There's no ADH activity at all, right? Because as soon as you stop drinking water, ADH should kick in and stop you from urinating, right? In diabetes insipidus, the problem is that ADH is not working, either because you're not making ADH, which is a central problem, or your kidney is not responding to ADH, which is a nephrogenic problem, right? In the central DI one, after finding out this point, the next step was supposed to be to give them desmopressin, and desmopressin would help, right? Because desmopressin can, it's an ADH analog. So you give them desmopressin, it'll do the same thing as ADH would, and basically their urine osmolality would be fixed. These are some of the basics of hypernatremia. These are really the only few case scenarios where hypernatremia can occur. And your question is going to be based off of either a diabetes insipidus question or some kind of question based off of weird presentations patients can have based off of whatever they're going through. And that's going to be one of these case scenarios down here. Now, what do you do for them? So first, determine volume status. If they're hypovolemic with unstable vital signs, then you need to use isotonic 0.9% NaCl before correcting free water deficits. So isotonic, why are we using isotonic? If the patient is hypovolemic, but they're hypernatremic, right? So they have low volume, and they have high sodium, right? This often makes people think that they should use hypotonic saline, and that's always going to be an answer choice, and you'll pick that and you'll get it wrong. The problem is that right now, look at what we're doing. This is the first step. The first step is to fix the volume. You want to fix the volume, not so much the sodium concentration per se, because remember, you're working with a fraction. This is a fraction, right? It's 145 milliequivalents divided by 1 liter. That's a fraction. You don't want to change both the numerator and the denominator at the same time, right? So you keep isotonic, which means that you're not changing this, right? Iso, the same tonicity, isotonic, but you are adding volume. So you're changing this. You're gonna first increase the volume, fix the denominator, get them to become stable. Then you can work on fixing the sodium concentration. Okay, so these are some things to keep in mind. Don't pick the answer choice of using hypotonic saline just because the patient is hypernatremic. It's a tricky thing that students definitely fall for if you haven't studied, and it almost sounds logical to use hypotonic saline in a person who's hypernatremic, but that's not logical. Right? You're not fixing both things at the same time. If you do end up using hypotonic saline, you would give them a lot of fluid that doesn't have high salt, and you wouldn't be able to monitor what you're actually changing. Is it improving or not? You want to change one variable at a time. If there's normal volume status and the patient is asymptomatic, then you can use the hypotonic thing, 0.45% NaCl. Okay, so basically volume needs to be fixed first. That's the main thing, right? Because being hypovolemic and being unstable, these two things lead to shock. Right? And if your patient goes into shock with low blood pressure, high pulse, getting all weak and stuff, and then losing mental stability, then it's going to become even harder to treat them, right? So even though it is definitely logical to give them hypotonic NaCl the very first time, understand this, that if you're changing all variables at the same time, you won't be able to figure out what you're actually changing, what's actually helping, and you don't want anyone to go into shock. So the first thing to fix is volume. And as you fix volume anyway, as you raise the volume, right, think about this too, as you raise the volume, you'll naturally be lowering sodium concentration. So you may not really need to do anything about giving them a different tonicity of sodium, right? So that's something to also understand there. Use isotonic NaCl until the patient is euvolemic, even with stable vital signs, right? Determine free water deficit. Water deficit is equal to total body water times serum sodium divided by 140 minus 1. Now, this is an equation. Do you need to memorize and know this equation? Not necessarily, not really at all. Water deficit, so a person having free water deficit really depends on what they're kind of going through. Things you should know, and we've looked at this in step 1 as well. So if we come back to right here, I think, yeah, one of the first things you learn about in renal physiology is this table, right? Where there's a pretty nice breakdown, and you need to know what's in each one of these colored rectangles. That's kind of what we're coming back to right here, right? So total body water is about 60% of a person's body weight, right? And they told you that this person's body mass was 70 kilograms, so 60% of that was 42 kilograms. And remember, in mathematical language, kilograms and liters is pretty much the same anytime you need to convert the two. So this person who's 70 kilograms, which is about 150 pounds, their body water is 42 liters, right? 60%. So that's the 60% you do need to know. So they'll tell you probably the mass of the person. They'll probably tell you the patient has like a weight of 70 kilograms, 80 kilograms, 50 kilograms, whatever they want to use, right? So you'll find out their total body water, and then in the question they'll probably tell you like how much their water deficit looks like. It's very, very unlikely they'll actually make you calculate this. But if they do make you calculate it, then you take the 60% of their lean body weight, which is basically their body mass. That gives you the total body water, and then you multiply that with the ratio of their serum sodium divided by 140. So remember, when normal sodium goes from 135 to 145, 140 is right in the middle, right? So this is not a new number, right? Normal sodium goes from 135 to 145. 140 is right in the middle. Okay, that's the 140 that's over here, and their serum sodium may be like, well, think about this actually. If their serum sodium is 140, which is actually normal, right? Then it's going to be 140 divided by 140, which is 1. 1 minus 1 would give you 0. And then total body water times 0 would be 0, which would mean that their water deficit is 0, which is correct. That makes sense, right? So in math, oftentimes when we ever had equations back in, I was a math major, right? So when I had equations that I didn't want to, or I couldn't memorize, all I needed to do was make sure I knew the number that would make this equation valid, right? Water deficit, excuse me. All right, so water deficit is equal to total body water, which is calculated using 60% of the person's mass, right? Multiplied by something like serum sodium, serum Na, divided by 140 I mean, minus 1, right? So then I know that the only way this equation would give me the valid answer of water deficit being 0 is if this is equal to 1, right? Because 1 minus 1 is 0, 0 times anything is 0. So this is not a ridiculously difficult equation to memorize. It's almost pretty logical and just commonsensical, and it should stick to you. And if you rewrite it a couple times, you'll never really forget it. So water deficit, total body water times serum sodium divided by 140 minus 1. This portion here, what can a person's serum sodium possibly be? So maybe their serum sodium is, if they're hyponatremic, right? If think about what happens when in this equation they're hyponatremic. So then your serum sodium will be 120, right? 120 over 140 would give you a small number, a number that's less than 1. And that would mean that you would get a negative number, right? If you multiply this out, you would get a negative number, which means that if your water deficit is a negative number, that actually means it's a water gain. So you can actually use this equation for water gain as well, okay? Which is what happens in patients sometimes, okay? And if their serum sodium is hypernatremic, so let's say this is like 160 serum sodium, then it'd be 160 divided by 140, which is a number bigger than 1, and you would get a positive number. That would be your water deficit becoming actual water deficit, right? You would get the legitimate water deficit the patient has, which is what actually causes hypernatremia. As we said, that only reason a person would be hypernatremic for the most part is because they have a lot of water loss, right? They're just losing all their water in their urine, like in these people with diabetes insipidus who don't have ADA, so they just urinate all their water out, right? Without any water to dilute the sodium, your sodium concentration becomes high, and that's hypernatremia. So this is why we care about water deficit. The number one primary thing in hypernatremia is water deficit. Anyone that's lost water, dehydration. Okay. So when I was saying in the beginning that for each one of these things you should be able to look at it and tell me the number one thing that causes it and what's going to happen. The number one thing that causes hypernatremia is water deficit. Central diabetes insipidus, or anyone that's dehydrated, period, right? And then you have to kind of help them with that water first, right? So this is why we use isotonic. We're not changing the tonicity, we're helping them with the volume first. Fix their volume, then worry about the sodium part later, right? They also write here, replace with D5W 0.45% NaCl or enteral water after you fix the water deficit. Determine rate of replacement. Now this is another thing that in step 1 it was not taught, but it was questioned. Because you can't fix somebody's sodium too quickly. If you fix it too quickly, whether you're fixing it from low to high or high to low, if you fix it too quickly, water will move with the sodium too quickly and the patient can go through some really nearly fatal problems. So right now we're fixing high to low, right? We're taking someone's really high sodium levels and we're going to try to make it back to normal. So we're decreasing from high to normal. Determine rate of replacement. Correction of chronic hyponatremia should be accomplished gradually over 48 to 72 hours to prevent neurologic damage secondary to cerebral edema. Okay, so now this is a topic of its own that they're not going to really dive into too much right there. But if we go back to here And let's see. Hopefully I don't pass it by mistake. Right here. Okay. So osmotic demyelination syndrome, right? This was also previously known as central pontine myelinolysis, massive axonal demyelination in the pontine white matter secondary to rapid osmotic changes, most commonly iatrogenic correction of hyponatremia, but also due to rapid shifts of other osmolytes like glucose. Acute paralysis, dysarthria, dysphagia, diplopia, loss of consciousness, and many other things, including locked-in syndrome, are things that can occur if you just don't correct the sodium well, slowly. So we just saw is 48 to 72 hours. That means that if someone presented with hypernatremia or hyponatremia, things that honestly never happen. It's never happened to me. It's not supposed to happen to anyone. It's a really bad case scenario. When that happens, it takes up to 3 days to slowly titrate and normalize a person's sodium levels, right? So this is the memorization tool that perfectly works for pretty much everyone. From low to high, your pawns will die, right? So if someone's hyponatremic and you're increasing their sodium levels, right? If you increase it too quickly, then that's going from low to high too quickly. Their pawns will actually get osmotic demyelination syndrome, which is what they're kind of showing you in this image here. And the person can just end up themselves dead also. Not only would the pawns die, they can die. So what happened here? Why did this occur? Well, you had a person who had a very low sodium concentration, which means that you remember salt and water, they go together. So if your sodium concentration is low and I give you more salt and I do it too quickly, all that excess salt pops up, pulls in a shit ton of water, and that osmotic damage that occurs from pulling in all that water that wasn't supposed to be there in the first place causes the demyelination to occur here, right? This is just really bad. This causes actual legitimate myelinolysis, lysis of myelin, and the pawns not working leads to a bunch of problems, as you can see from this list, which of course can lead to the person dying. The other one is from high to low. So from high to low, your brain will blow. Right? Very easy to memorize. This is a nice little rhyme, perfectly sticks. Plus low and blow, right? High and die. It all works out. So if you go from very high to low, what happens? Well, this is a person who, for some reason, ended up getting high sodium, right? Whatever they did, we're imagining maybe they're dehydrated, so they became very hypernatremic. If you just fix their sodium and pull all the sodium out, you also end up pulling all the water out, and that's edema, right? Remember, never does our body have edema until we have problems of sodium moving around in weird places, right? That's one of the major things that causes edema. And cerebral edema can also present with herniation of the brain, and then herniation of the brain is coma and death, right? So you need to fix these things really, really carefully, very carefully, right? And that's kind of what's being described here as well in this little breakdown down here. I put this note into the book after one day where I was doing my rotations with the internal medicine doctor, and he asked how would I fix high sodium, and I had no idea. Besides telling him that I would have to take my time with it and not do it rapidly, I couldn't tell him this. I still wouldn't be able to tell him this because I wouldn't remember this. But by putting it here and having looked at it, I remember it enough so that when I ever do see it in a question, I know that I'll be able to pick this answer choice as long as I can see the answer choice, but I don't have it memorized, right? And corrected sodium does have this equation. Now, the equation aspect of things, this one for corrected sodium, you don't have to memorize because it's just too many weird numbers to memorize. This equation is not going to work out, so don't really try to memorize it, but it's good to have a basic visual of it, just knowing what it looks like. So like in this question, what they're showing is this person corrected sodium is equal to their sodium concentration, which is 129, plus 2.4 times whatever their glucose concentration is, minus 5.5 divided by 5.5, and they got 129 plus 8.5, which then puts it into 137.5. What this tells you is that their sodium is now corrected. Even though their current sodium concentration may look like 129, it's corrected. You just need to give it time. You need to wait. This is why you do it so slowly, because sometimes you might have actually fixed the sodium concentration, but because of other things that are in the human body, like glucose and other electrolytes and how quickly your fluids are shifting, even though you've already fixed the sodium concentration, you may not be able to see that right away, right? So this equation kind of helps you see that, but not, not something that useful, because it's such a bad equation. It's not that pretty, nor the numbers that nice, so it doesn't really stick. I haven't been able to memorize that equation. This one I remember though. This one I remember. Total body water multiplied by serum sodium divided by 140 minus 1 is going to give me my water deficit. That one I remember. All right. So always remember, you fix the volume first. If the person's volume is fixed, then you can move to 0.45% NaCl. Otherwise, no. Right. So that was basically your revisitation of the osmotic demyelination syndrome, which is also now still relevant for the next part, hyponatremia. So what are now the number one things that can cause someone to become hyponatremic? So hyponatremia would really just be, a mixture of either you're drinking, well, how would you make your sodium concentration really low? So you're either drinking way too much water, so you've diluted yourself, right? Or you have SIADH, which is the opposite of diabetes insipidus, a person who has too much antidiuretic hormone, so you don't diurese at all, right? So you're retaining all your water. And we're going to see a good list of things. Hyponatremia is more commonly tested than hypernatremia because it's a little more confusing for some people. So now your serum sodium is less than 135, right? Normal is 135 to 145. Hyponatremia is most commonly caused by high ADH, which is most commonly seen in SIADH, and it can also be in some lung cancers, right? Small cell lung cancer can also release ADH, which would be basically another variation of SIADH. However, there are some ADH independent etiologies like primary polydipsia, a person drinking too much water, starvation, where you just don't have any salt intake at all. Remember, you can't make water and you can't make salt, right? This is why in dehydration, when you lost water, your body can't do shit about it. And here in hyponatremia, if you lost all your salt, once again, your body really can't do shit about it, right? Can't make mass. And the last one, the presence of a non-sodium effective osmol in the extracellular fluid, which is the most confusing one, so we'll see that when we get there. Patients may be asymptomatic or may present with confusion, lethargy, muscle cramps, and nausea. Can progress to seizures, coma, or brainstem herniation. But the number one thing to remember with sodium in general is if you're hypernatremic, chances are you're probably hypertensive also, right? Because salt causes hypertension. And the opposite is true here, right? If you're hyponatremic, chances are the person doesn't have high blood pressure at all, right? Doesn't necessarily mean they might be hypotensive though. Understand what I said, right? I said that if you're hypernatremic, you're most likely hypertensive. But if you're hyponatremic, you're not hypertensive. But I'm not saying that you're definitely hypotensive. It doesn't have to be. There are other things that manage blood pressure as well. So salt alone isn't the only guy responsible for blood pressure. But being hyponatremic means that there's really no reason for the person to be hypernatremic. They're hypertensive. There are other things that also increase blood pressure, but they won't act unless the person has some kind of specific reason to make that thing happen, right? So we'll see more of that as we get there. So they don't mention blood pressure as like, history and physical exam stuff, okay? But it is a thing for both. We all know sodium and whether it's sodium high or sodium low is directly related to blood pressure being high or blood pressure being low, right? And then other factors play a role as well. So you look for all of that. Now, what do you do? So best initial test, measure their serum osmolality as the first step in evaluation. If the measured serum osmolality, their serum solute concentration, is higher than the calculated serum osmolality by more than 10 to 15, then this indicates an exogenous osmol, right? Some non-sodium osmol diluting the serum sodium. This ends up being too hard to do. You're not going to remember this equation, nor are you going to want to remember this equation. Now, you could put this together. You could write this equation down. You could have it on your cheat sheet. You could try to memorize it, and then reproduce it on your cheat sheet, which is basically what, I'm going to recommend doing. Create your cheat. I already have a step 1 cheat sheet that I put out that students buy. There's a step 2 cheat sheet as well, which has these equations on it. And the point is supposed to be every morning before you start studying, you rewrite that cheat sheet for yourself. And by doing so, you create a muscle memory and neurological memory of the topic, and then it sticks to you a lot better than trying to look at it just the week before your test. Basically, that's not the way you want to try memorizing it. So this is going to come off of information they give you. So you're going to take, to find out serum osmolality, you double their serum sodium, add BUN divided by 2.8, and add glucose divided by 18. The 2.8 and the 18 are numbers that were discovered by scientists who figured out that that was the best way to basically measure this. All right. And when you do this number, serum osmolality turns out to be 10 to 15 more than the serum osmolality that was given in the question, then that means that something else, some exogenous osmol, not sodium, is actually causing a dilution in their serum sodium, causing them to become hyponatremic. That's all this is talking about. Correct the sodium in hyperglycemia. Sodium decreases by 1.6 milliequivalents per liter for every 100 milligrams per deciliter elevation in glucose. Okay. Hypotonic hyponatremia is the most common and is further categorized by volume status. Now, this table down here basically tells you everything. So far, as you can already tell, hyponatremia already looks a little more confusing than hypernatremia. But let's take a look at this table first to understand what's happening. So you get a patient, their sodium concentration is less than 135. So maybe it's 120. We'll just say it's 120, right? 120 is less than 135. So we have a patient right now whose sodium concentration is 120 for whatever reason. So we need to figure out what the reason is. First thing we check is their serum solute concentration, because there's other solutes as well. Now, if their solute concentration is 280 to 295, which is normal, then that's isotonic. So now you need to measure lipids and protein. Okay, you need to measure lipids and protein, figure out what else is happening. How are they doing otherwise, right? Are they having some kind of hyperlipidemia? Do they have hyperproteinemia? What's the actual problem there? If their serum osmolality is low, so not only are they hyponatremic, but their solute concentration in their serum is also low, then all in all, they're hypotonic. Right? Hypotonic. So now you need to clinically assess extracellular fluid volume. Why are they hypotonic? What is making them hypotonic? Right? Because hypotonic means that you have low solute and a lot of other stuff, a lot of fluid, a lot of water basically. So you need to figure out, is this like some kind of water retention issue? So now this has 4 different major issues here. If you assess their extracellular fluid volume and you find out their extracellular fluid volume is also low, that's the weirdest, right? Because they're hypotonic, but hypotonic meant they don't have much sodium and they don't have much water. So how are they hypotonic? What happened here? So this is the case scenario of hypovolemic hypotonic patients, right? Hypovolemic because they don't have any water, and hypotonic because they also don't have any sodium. Where does that occur? The number one case scenario where this occurs is diuretic abuse. Someone who's trying to use diuretics to try to lose weight, right? You don't end up losing weight at all. You actually just end up losing a lot of your water weight. That's it. Other case scenarios are going to be based off of what their fractional excretion of sodium is, right? So in diuretics, fractional excretion of sodium is high. Basically, they're excreting a lot of sodium. They're urinating a lot, and they're urinating a lot of their sodium. So that explains the hypovolemic hypotonic, right? If you urinate a lot of water, you're becoming hypovolemic. And in that water, if you're also urinating a lot of the sodium, then you're also hypotonic. It also occurs in urinary obstruction, adrenal insufficiency, and bicarbonate urea, right? Any case scenario where you're urinating a lot of your bicarb. So now these case scenarios, these answer choices end up being very hard to pick because you have to understand how each one of these things actually causes hypovolemic hypotonicity with a high fractional excretion of sodium. I just explained the diuretic one, right? That this is a person who took diuretics, urinated all their water, so they became hypovolemic, and in that water they urinated all their sodium, so they also became hypotonic. Right? But they are not urinating all electrolytes, just sodium, some other things, but mostly sodium. You also have to imagine who the person is that's doing this, right? If it's a skinny girl trying to lose more weight because she thinks she's overweight, then that's basically an anorexic girl who has anorexia nervosa. It can also be a bulimic person, bulimia nervosa, using diuretics as a coping mechanism to their eating, right? All kinds of those patients will definitely have major changes in their electrolyte abnormalities because of their weird eating habits. So this is the list of things that are going to have a high fractional excretion of sodium. Here, fractional excretion of sodium is not going to be high. Okay, these are all the case scenarios which are also hypovolemic hypotonic patients. For example, if you have a lot of diarrhea, a person who's been going through diarrhea because of some kind of infection or something, and is giving off loose stools, watery stools, not the fatty stools though, just mainly watery stools. Although fatty stools fits here too, but they're probably not going to say fatty stools in the question because that can confuse you with some other diagnoses as well. So if a person has diarrhea, let's just say diarrhea, right? In diarrhea, you lose a lot of water. Right? Every time this person goes and takes a pooping session, loses a lot of water in their feces. That takes away the volume. And because it's diarrhea, it means that they're not really absorbing a lot of the things very well, so they also become hypertonic. They lose their sodium, right? Same thing with vomiting as well. And this is also going to be true for bulimic patients who force vomit, right? Forced vomiting pulls back out all the things you ate. So then, of course, you lose a lot of water with that vomit, and you lose a lot of electrolytes. Once again, hypovolemic, hypertonic, right? So you can see everything in this list over here on the low side where the person has low volume and has hypotonicity, low solute concentration. These are people that basically have gotten rid of things that they didn't really get to absorb. All right, that's your first case scenario. Now let's come back to the beginning. So you have a person with hyponatremia, you measure their serum osmolality, turns out they're also hypotonic, which makes sense. For anyone hyponatremic, I would hope they're hypotonic. Anything else would feel a little weird. Okay, honestly, case number 1 and 2 over here, these are pretty weird. If you don't have any solute in you, then you should have a low solute concentration. So when a person who doesn't have any solute is somehow isotonic, or doesn't have any salt and is still hypertonic, those are pretty weird, right? That doesn't really make much sense. So case 1 and 2 can be confusing in questions. Case in the middle here is the most straightforward one. You don't have any solute, so you're hypotonic. So now I'm going to measure how much volume you have, because anytime I deal with your solute concentration, first thing I need to fix is your volume. Turns out your volume is normal, right? Isovolemic, but you're just hypotonic. So if your volume is normal, but you lost salt, then if you're retaining volume, that means you're able to drink water. This is a person who's able to drink water, is not dehydrated, right? But for whatever reason, their solute concentration, their Na sodium concentration is low. So the first case scenario is this one, where the urine osmolality is more than 100, okay, often more than 300. What does this mean? So what we needed to check, right? This is the order you always go in. First, you check their electrolyte, found out they have low sodium, 120. Then we check their serum solute concentration, find out that's low. Now we check their urine solute concentration, see if it mimics their serum solute concentration. Turns out their urine concentration is very high. This is very concentrated urine where basically they're not really urinating. They're not urinating at all. They're not urinating any water. So they're retaining water, which is why they're able to stay isovolemic, but they're losing salt, so they become hypotonic. This is the notorious case of SIADH, right? SIADH actually has a lot of issues. In a person with SIADH, not only is the ADH a problem, but then when your own body tries to fix things, we've already seen that with heart failure. Anytime your own body tries to fix things by itself, it will further mess it up, right? The simplest example of that is when your body tries to fix a scar, right? It makes scar tissue, which obviously is not exactly how things were before. At that point, you'd be better off if your body didn't try fixing it and maybe just used stem cells like it made it the first time. So look at what happens in SIADH, right? You got a person with a lot of water retention because they have too much ADH, antidiuretic hormone, so they're retaining all their water. All that water retention makes them have normal volume though, because they're actually just this is the most significant thing in these people. They're gonna be euvolemic. In questions, this will be described as a person who everything about the question may look like the person's somewhat sick, but then they'll tell you mucous membranes are nice and moist. You know, they'll have that one sentence just saying that mucous membranes are moist. Anything to tell you they're not dehydrated. And that's when it should ring a bell. That the fact that the question writer spent a sentence writing down something that told you the patient is not dehydrated, that's a sign of SIADH. They're euvolemic but hyponatremic with continued urinary sodium excretion. their urine solute concentration is much higher than their serum solute concentration. And then watch how your body tries fixing it. The body responds to water retention with decreasing aldosterone and increasing ANP and BNP, which then causes you to lose even more sodium, further worsening this. Right? This is what's really unfortunate. All of this is what normalizes the extracellular fluid volume and lets the person be euvolemic. So your body is able to maintain volume, but you're still hyponatremic. Now, although this may sound like something stupid, this is actually pretty genius, right? If it sounded genius to you, then great, you caught it correctly. This is great that the body does this because we just saw this, right? We just saw that when we were fixing hypernatremia, when we were fixing any hyponatremia, the first thing we need to do is use isotonic fluids and fix the volume, right? Fix the volume first. Fix the volume first. So your body already took care of it, right? In SIADH, your body has already fixed the volume. Now all you need to do is increase their salt. Give them like a salt pill or something, right? And that's actually one of your things, right? Salt tablets, one of your treatments. Give them a salt tablet here. Tell them to stop drinking water because they're retaining all the water they drink. Use hypertonic saline and stuff like that, right? Use diuretics, but the main thing is to fix whatever's causing the SIADH also, right? If you know what's causing it, one of these four things, then you need to get rid of that. So that's kind of what you're seeing on this left side. On the right side is probably the least dangerous issue. Either primary polydipsia, someone who has some kind of psychotic diagnosis like schizophrenia or a mood disorder like bipolar disorder, manic disorder, stuff like that. Taking medication, those psych medications make you really thirsty. On top of the fact that they're already a little psychotic, primary polydipsia is also referred to as psychogenic polydipsia. These people are just drinking too much water. It's evident that they're drinking too much water because not only is their serum hypotonic, but they're also urinating hypotonic urine. Right? Urine osmolality is low, which means that they're urinating all their water. Right? They're drinking a lot of water and they're urinating a lot of water. That's the least dangerous thing because this is true for any of us. Right? It's true for all of us. Everyone who has normal renal function and doesn't have any of these disorders, if you're drinking a lot of water, as a healthy individual, you're going to urinate a lot of water. That's what you see in this first case scenario. The other one, beer drinkers podomania, which pretty much everyone's going to go through this week after 4th of July beers. This is just anyone who had a lot of beer. Beer is also mainly, besides the carb aspect of it, it's just a lot of fluid, right? It's a huge fluid intake, which is similar to a lot of water intake. So it ends up presenting in a similar manner. Right, nothing needs to really be done for these case scenarios. There's no real issue here, right? It's all going to normalize when they stop doing either the excess beer intake or the excess water intake. That's it. No real treatment necessary though. Don't pick a medication. And then the last thing here, you got a person with low sodium. You check their serum osmolality and that's also low. So they don't have much salt and their salt serum concentration is low. You then check their volume and their volume is somehow high. So if you have a person with low solute concentration and a high volume, then you need to think of all case scenarios that can cause high volume. Right? And that's going to be CHF, nephrotic syndrome, kidney injury, chronic renal failure, all of these things. Right? And each of these on the left and the right, you can see are differentiated by how much sodium excretion you have, the fractional excretion of sodium, whether it's less than 1% or more than 2%. This also goes back to step 1 renal. Let me show you where that is. Yeah, right here. And so if we look at this table right here for acute kidney injury, the topic of azotemia, then you can see right here is the fractional excretion of sodium as one of your parameters, right? Now, there's pre-renal azotemia, intrinsic renal failure, post-renal azotemia. What does this mean? So pre-renal is your blood vessels, right? The blood vessel that comes to the kidney, right? In the middle here is your kidney, right? Bean shaped, and then over here is your bladder, right? So the ureter is coming into the bladder, right? So you have your two ureters that come into the trigon of the bladder. That's what you have in post-renal azotemia. So ureters and bladder, kidney, and then the blood vessel that's actually bringing blood to the kidney, right? So these are your 3 different parts that are being discussed by these 3 different columns here. Okay, pre-renal azotemia means that something's wrong here. So it could be a person who's hypovolemic, as in dehydrated, doesn't have enough cardiac output, or has some decrease in effective circulating volume for other issues like heart failure, liver failure, right? All of these three case scenarios would reduce how much blood I'm going to bring to the kidney. Sounds good. This is why it's called pre-renal. The problem isn't in the kidney itself, it's in the things that come before the kidney. So now in these patients, what do you see? Pathophysiology. Decreased RBF leads to decreased GFR, right? Renal blood flow went down, so you have decreased filtration rate. With decreased filtration, you have more reabsorption of sodium and urea. Remember how filtration was working? We looked at, well, we haven't looked at it in the CK class, but let me go back and that was somewhere up here. So the way that filtration was working, we're looking at this word right here. It depended on how much blood came into the nephron, right? Which means that all the blood that came into the kidney got divided into multiple different glomeruli, and then it goes into the nephron. And in here, you do filtration based off of, most notoriously, this. This is why this has the fattest arrow, right? The amount of pressure inside the glomerular capillaries. So if you don't have much blood coming, and you don't have much pressure in here, you won't do much filtering, right? Filtering means that you took it out of the blood and you put it into Bowman space, and then it goes into here where you may reabsorb it, you may secrete a little more of something depending on what the thing is, and the rest just goes into the ureter and gets excreted, right? When it eventually makes its round around and gets to the collecting duct, it goes to the ureter and gets excreted. We also understood that of the things that are reabsorbed and secreted, the thing that were secreted were mostly like creatinine. We saw this right here, right? PAH and creatinine, somewhat secreted. And the things that had a U in it, inulin and urea, there's no secretion at all. It goes straight into urine. Whatever you filtered goes straight into urine. You don't secrete more of it, nor do you reabsorb it. What gets reabsorbed? Things like sodium and anything else you might need, like glucose, those amino acids, those things you can reabsorb over here in the peritubular capillaries. But what we're looking at right now in pre-renal azotemia tells you that this is not working very well. So then this ends up not working very well, and then this ends up not working very well. That's what we're seeing in pre-renal azotemia, right? So let's go back to our table of pre-renal azotemia real quick. So that's this list here. So then, of course, you end up having more reabsorption of sodium in water and urea, okay? Because you didn't get to filter much of it, right? If you didn't filter much of it in the first place, it just stayed in the blood. And that's why fractional excretion of sodium in any of these case scenarios that are pre-renal will always be low. You don't need to remember less than 1% per se, but you can. It's just that it'll be low. Now, if you look at intrinsic renal failure, this is where the kidney itself is failing. The kidney does not work. The nephrons inside your kidney do not work. Why? Maybe you have acute tubular necrosis. Maybe you have acute interstitial nephritis. Maybe you have renal papillary necrosis. Maybe you have any other issue inside the kidney that doesn't let it work, right? You glomerular nephritis, vasculitides, malignant hypertension, thrombotic TTP, right? Thrombotic thrombocytopenia, HUS. There's a bunch of things that can cause the kidney to not work. When the kidney doesn't work, you basically see some kind of issue that, of course, reduces GFR. Right here, they gave an example that's the pathophysiology of ATN, acute tubular necrosis, the first thing. But no matter what thing you pick, the point is GFR is going to be low. Now, in this case scenario, though, your fractional excretion of sodium is going to be high, because at this point, what's happened? So in that point, what's happened is you made it in, because heart failure was not a thing, right? Heart failure is pre-renal. So now at this point, you've made blood come here. It came in here with good pressure. It did this. It filtered. But then after this, because the kidney is failing, right, you ended up just excreting everything, even though you were supposed to reabsorb it, right? The main part that the kidney is most important for is not just urinating things, but actually making sure that you're only urinating things you didn't need, right? That's what the kidney is for. You want to urinate things you didn't need while you retain things you would prefer to retain, right? And in our person, oh, right, and in our person here with intrinsic renal failure, your kidney is failing at retaining things you needed, so you end up urinating more sodium than you needed to. And of course, when you urinate sodium, you often end up urinating more water too, right? So you can see how urine sodium is more than 40, right? Urine solute concentration is less than 350 though. Why is urine solute concentration low if you're urinating all this solute? Because with all that solute, you're also throwing away a lot of water. Remember, another thing the kidney is supposed to do is retain water too, help you keep water, but it can't because you have renal failure. Right, so what part was that? That's the collecting duct. The collecting duct won't work in retaining water using aquaporins and ADH. It won't be able to do it. In intrinsic renal failure, you have low urine osmolality, low urine solute concentration, because the water is your urine is full of water, not because your urine doesn't have a lot of solute. Your urine does have solute, right? So these 2 points, are kind of counterintuitive until you understand the full picture, right? Urine solute concentration, when your kidney is failing, urine solute concentration is low because you pissed out a lot of water, but you also pissed out a lot of solute, right? It's just that you pissed out more water than the amount of solute you actually urinated. Okay, and for pre-renal azotemia, the notorious giveaway is usually this thing: serum BUN to creatinine ratio. Like, they might tell you that the person's BUN is like 47 and creatinine is like 2, right, 1.5. So then of course that ratio of, let's just use better numbers. Like, let's say they tell you BUN is 50 and they tell you their patient's creatinine is 2, right? The 50 divided by 2 is 25, which is more than 20, right? And that's kind of what's going to happen. So you're going to have a number that's bigger than 50 and this number that's possibly less than 2, between 1 and 2, because their kidney is not going to be that good. It could be 1, 2 though, right? Even though they have azotemia, depending on how long it's been, their kidney may still be okay, because this is pre-renal azotemia where the kidney itself is somewhat working fine, right? So creatinine could be 1 and BUN would be 50. That's also more than this, right? Basically, this BUN to creatinine ratio will always be high in this case scenario, obviously, because the denominator is not messed up. Creatinine is not so bad. This is pre-renal. The kidney is working fine. Creatinine is going to be good, which is 1. Creatinine should just be 1. So as soon as your BUN is more than 20 in these people, 20 divided by 1 is 20. So as soon as it becomes 21, 21 divided by 1 is 21. It fits pre-renal azotemia. Understanding these things should not be so hard, but you have to spend some time like we are right now to get it. So, good job on all of us that are doing this right now, and you would never forget this. Last thing here now is your post-renal azotemia. So this is after the kidney. So in post-renal azotemia, this is working, the kidney is working, but something after the kidney. So remember, this is connected here, right? This is connected like that. The ureter, right? All the filtering that happened ultimately gets connected into the ureter, and then it goes to the bladder, and the person urinates. Something is going to stop that, but because this is post-renal, this is actually going to have a backup and mess up the kidney too. Keep that in mind. Depending on what the problem is, although this is not intrinsic renal failure, the person will have secondary renal failure because of urine backing up, right? Like, this can cause hydronephrosis, as we've seen. So the person might have a stone in the ureter. The person may have benign prostatic hyperplasia, which would be causing compression here, right? Actually, BPH would be causing compression after that. It would be causing compression after that in the urethra, right? Somewhere here. So the bladder would be full, urine will back up into the ureter, and then back up into the calyces, and again the kidney is going to get messed up. If there's a stone in their singular ureter, then it'll be unilateral problem, where urine is just going to back up here and in there, right? Could be a cancer somewhere, any kind of cancer that's causing compression of these things. Again, same thing. And then of course various congenital anomalies can also cause the same issue, right? But these are all post-renal azotemia. So what happens here? Well, it really depends. So we don't really need to worry about this. It just really depends on what's the real problem, right? And once again, you're seeing urine solute concentration low, because there's just no reason for this. Why would your urine solute be high? The only time your urine solute is high is here, right? And if you remember pre-renal azotemia as heart failure, then you would remember heart failure has atrial natriuretic peptide, ANP, BNP. All of those guys are going to cause you to urinate a lot of sodium, but not urinate a lot of water, because in heart failure and all these other case scenarios, you usually don't have much volume to urinate anyway. They're hypovolemic patients. So this is a lot of solute being urinated out, which is why it's very concentrated urine. Also in heart failure and in some of these other case scenarios, these patients release other hormones that retain water. Like in hypovolemic patients, you'll have ADH. So if you remember, this is really hard to type sometimes. It stops. Look at it. I'm making a line, and half the time it's making. Look here, it didn't make this portion of the line at all. I don't know why it does that. Anyway, ANP and ADH, both of these things are being released in this problem, pre-renal azotemia. So the ANP is causing you to release a lot of sodium in your urine, but ADH is retaining water. Boom, combine those two issues, you get a really high osmolarity of the urine. Very concentrated, salty, no water urine. Right? So memorizing these numbers is not really a memorization game, it's just an understanding of what's happening in each one of these three case scenarios. Which basically wraps up the topic of acute kidney injury, right? Because that's later on. That's going to come up. Acute kidney injury and chronic kidney disease. So you need to know on these two, right? We've only looked at two things, hypernatremia and hyponatremia. And that alone already took up pretty much all the time, because literally there's so much involved, especially in hyponatremia. So you want to make sure you get this stuff, right? And the first two case scenarios, these two on the left and the right, where the person is either isotonic or hypertonic, even though they're hyponatremic, those are weird. Those are case scenarios where something else, this is what we have to calculate, right? Some other non-sodium osmol is diluting the serum sodium, where basically the person looks hyponatremic simply because something else is causing dilution of their actual sodium. For example, here lipids are doing it, and here glucose is doing it, right? Glucose is doing it. Why is glucose doing it? So if a person has diabetes, where their glucose is more than, this is like someone with DM, either 1 or 2. So now their glucose is like more than 200. Like let's say it's more than 200 glucose, right? So that's a lot of sugar floating around in their serum. So why would this person look hypertonic? Because the sugar itself directly. And what does all that sugar do? It pulls in a lot of water, because glucose is an osmol, right? Sugar does pull water. And now it looks like they don't have much sodium. That's all that's happening here. So this is a person who could be maybe someone going through diabetic ketoacidosis, right? There you would see this. That would be a person with extremely high glucose, forgot to take their insulin, DM1 patient, super high glucose, maybe like 500, and that would be a person that would present hypertonic because the glucose is increasing tonicity, but they would look hyponatremic because the water retention, glucose being the other osmol, the water retention is kind of diluting their sodium. But they don't actually have true hyponatremia. They have sodium, right? So you see why from way in the beginning we talking about actual numbers and concentration, rather the difference between the two, right? It's not that a person is supposed to have 145 sodium. No, you have 145 sodium for every, right? This is milli equivalents for every 1 liter of serum. This is a concentration, it's a fraction, right? This fraction can get diluted, and that's what's happening, right? In each of these different scenarios, because you're changing the amounts of liters of the denominator, how much serum you have. You're not changing the amount of sodium this person has. How much sodium they have in their body, we never calculate. We can't calculate. We can try to calculate it by knowing, if it's 145 per liter, and the person's body consists of 42 liters, then we just multiply by 42 liters and we'll get their total number of how much salt they have in their body. But that information doesn't give us anything, right? It's not really that helpful, and it's a different number for every individual. But the division like this is not different for every individual. All of us throw our salt around in our body the same way, as long as everything's working, okay? So these two case scenarios depend on this stupid equation over here, right? And this stupid equation is one you have to put on your cheat sheet and memorize. Okay, and you just rewrite that every day, because if you don't, then this might be an easy question that you might start getting confused by and start picking one of these other things. And remember, they're both weird scenarios. They're both weird scenarios because you're telling me my person has low solute, yet they're isotonic or they're hypertonic. That's weird, right? So that means if I have a person with low solute, if I have a patient with low solute and they're isotonic, something else is increasing tonicity and maintaining isotonicity. And same thing here. If my person has low solute but they're hypertonic, once again, something else is increasing their tonicity. So here it's glucose. In this case scenario, it's lipids. Mannitol is on both case scenarios, so you won't really get a question on mannitol unless they really specifically tell you the person took mannitol. Then you have to think of this. Otherwise, no. All right. And I think that's about it for all that. Next one. Now from here on, it'll get a little easier. The next few things like hyperkalemia, hypokalemia, they're not as bad as the sodium stuff is. So we have a practice question here. That's great. Let's take a look at it. What is this? So you have a 37-year-old man admitted to the hospital due to a 10-day history of fever, non-productive cough, dyspnea, and exertion. He has a history of HIV for 10 years and has been non-compliant with medications. Alright, so he wants to die. Or maybe he's too poor to actually afford it, then that's just sad. 37, has fever. Okay, so HIV, fever, 37, probably has some infection. Vitals looking okay. Pulse ox is good, not the worst. BMI is 20. Physical exam reveals bilateral lung crackles. Okay. Chest X-ray reveals bilateral interstitial infiltrates, so he has some kind of pneumonia maybe. He started on appropriate antibiotics and IV normal saline. Alright. 2 days later, his dyspnea has improved, but he develops confusion. Repeat vitals show temperature, blood pressure, pulse, respiratory rate are all looking fine. Mucous membranes are moist. Oh, see, anytime you ever see this sentence, it should be a giveaway for the answer, especially if right after that sentence you see the answer choice. There is no JVD. Lung exam shows better air entry with reduction of crackles. Okay, so they fixed him. No JVD means no jugular venous distension, so his right heart is good. Nothing's backing up. Lung exam shows better air entry, no more crackles, so his pneumonia is pretty much cured. Heart sounds are normal. Once again, they say no JVD. I'm not sure if that's actually what they said or if I just wrote it twice. And then they say, oh yeah, I definitely wrote it twice, excuse me. Heart sounds normal. There is no peripheral edema. That's good to know. Labs of serum chemistry on the day of admission versus today are given. Okay, so now they're just trying to confuse you with extra numbers to toss at you just to kind of play around with your mind, if anything. So they tell you on admission, this is how stuff looked. Alright, so if you look at it, his sodium was a little low, below the 135. Potassium was normal, chlorine, bicarb also normal, BUN 12, creatinine 1, everything else not so bad, right? And then all of a sudden, for some weird reason, today, things are not looking so good. So let me move this so that it's actually under each other. There you go. So now we're seeing sodium has got even lower for some weird reason, right? Potassium, normal still. This is normal, that's normal, BUN is normal, this is also okay, everything else is okay. So the only change between admission and today is the sodium became lower. It was low to begin with, it became even lower now. Total IV intake of normal saline since admission is about 5 liters. What is the most likely cause of his hyponatremia? So then you look at your answer choices, right? You see the answer choice of SIADH. And then you also see the other answer choice of dilutional hyponatremia with suppressed ADH secretion. And of course, most people picked it. right? 50% of people picked it. It's pretty interesting and very easy to fall for this trick too. Why would you pick this? Because he was given 5 liters of saline. But the real thing to think about here was, why would his ADH be suppressed? Right? Do you see any reason his ADH would be suppressed? Because I don't, right? This is a psychology game. You fall into the wrong answer very easily when your brain is out of exercise because you haven't practiced in practice questions, but also when your brain is just burnt out. When you're burnt out, and this is the kind of shit that happens when you're doing practice questions, and then you see that you picked the same wrong answer as 50% of people, you feel a little better about it. But the truth of the matter is, you actually fell into the same trap a lot of these other people fell into, and that's not something to feel better about. You should never feel bad about doing bad on a question, but it's just not something to justify. Don't justify it. This is actually serious. These people that picked that answer choice, right, were actually thinking that because he was sick and he was given all this saline, we caused a dilution in his sodium concentration. If that was the fact, then this would happen to pretty much every person we ever give saline to, right? Logic. But that doesn't happen. Second of all, if we did cause dilution, why would we suppress his ADH? How? What is suppressing his ADH? Anytime you have too much water, you would have no ADH, right? And you would actually urinate because you need to get rid of it. So if you have a dilutional hyponatremia, but the person is diluted, right, then sure, you're not going to make ADH, but you should be urinating. There should be no reason for you to have a dilution in such a weird way, right? This answer choice was a very good trick answer choice that a lot of people fell into. But as I said before, when we were talking about SIADH earlier, that the writers of the question for SIADH will always mention a person who's looking a little, dehydrated, because clearly sodium is very low, right? Think about everything we just did on our tables too. Our sodium level is very low. And a person whose sodium is low, what happens? Well, if you lost sodium, you probably either retained a lot of water or you lost some water and lost sodium with it, right? There's many different ways it can occur. So how are we supposed to measure this issue? Our patient showed up right now in this question, right? This guy's sodium is 124, which is close to our example here, 120, sure. So low sodium, okay, what do we do with him? Check his serum osmolality. Can we check his serum osmolality? Not really. They didn't necessarily give it to us, right? They didn't give it to us. But they did give us numbers like the BUN and glucose to use that equation, 2 times serum, right? Serum glucose, serum BUN, dividing all that. We could, theoretically, if we remember this equation, right, the serum osmolality equation, if we remember this, we could calculate it. But let's say for a second that you didn't spend time memorizing the equation, didn't really create a cheat sheet, and then didn't really have the equation ready for the test, right? Then what would you do? Well, as soon as you read that his mucous membranes are moist, the safest answer choice to go with is SIADH. That's pretty much when you're doing practice questions, if you ever see a question that says the answer is SIADH, check the question again and see if they wrote that mucous membranes are moist. That is the first thing you'll see, right? That's always one of the safest ways to go if you have no other way to answer the question. Mucous membranes are moist, but the patient isn't doing so well. SIADH, right? Other thing you can do. Well, all his other solutes are looking pretty decent, right? His glucose amount is normal. So this means that I'm not going to pick this answer choice, right? It's not like this. That means he's not hypertonic, right? If all his other electrolytes are normal, there's no way he's hypertonic, right? So what I'm trying to do right now is trying to help you guys figure out how you will solve this question if for whatever lazy reason you didn't memorize this equation, which there's going to be a lot of people that aren't going to have the equation handy. Or you tried memorizing it, but you didn't create a cheat sheet. Or you tried everything, but then you forgot when you were trying to rewrite the cheat sheet. No matter what happens, if you don't have this equation, what can you do? Well, look at things you care about, right? You care about glucose. You care about BUN. Remember, at the end of the day, an equation is just a sentence. It's telling you a story. This is a paragraph, if anything, with every plus and minus sign being another sentence. So we care about glucose. We care about BUN. All right. So what are we going to do here? So in our person, glucose is normal. And BUN is not looking crazy high. It's up there, but it's not excessively high. Excessively high is when it's more than 20. That's what we really care about. In fact, how do you even get that down? So if we come back to this equation, right? Let's work this equation out for a person with normal serum sodium concentration. Normal sodium would be 140, right? So 2 times 140 would give you 280 right away, right? And normal tonicity is 280 to 295. This is normal. So if your sodium concentration is 140, you already brought it to a normal. Now you're going to add BUN divided by 2.8. So if your BUN is like 2.8 is such a weird number, which is why I don't like this equation. But let's say your BUN is like 28. That's easy to divide. So if you do 28 divided by let's just say 28 divided by 2, right? That gives you 14. So you're going to be adding like 14 here, right? And then glucose. Well, normal glucose is supposed to be like 100, but for division purposes, we can use something like, I'll just use my phone. Fuck it. This is why this equation sucks though, because the numbers are not easily dividable. So I wanted the BUN to be 10, right? So 10 divided by 2.8 gives you like 3.5 actually. Okay. So because I want BUN to be like an acceptable, not crazy BUN. So because we're trying to find normal serum osmolality. So this is supposed to be like 10 divided by 2.8 would give you like 3.5. Okay. And then this is a plus sign. And glucose we're gonna say is normal like 100. Okay, 100 glucose is not so bad. So 100 divided by 18, that gives you 5.5. And you see how these numbers, if I add these numbers up, I'm going to be within this range. 3.5 plus 5.5 is 9. So that's going to be 289. So you need these numbers to be within normal range. And if they are in normal range, then you know it's not this or this. And you can cancel those answers out. So we know in our person, glucose is normal. It's like around 100. We also know in our person, BUN is not crazy high because it's 10 and 12. But both times they gave you the numbers, right? BUN is looking good. Glucose is looking good. Nothing crazy. All the other electrolytes are also okay. Which means that there's no way our person is going to be hypertonic, right? And really no way our person is going to be per se isotonic. So our person must be hypotonic, which comes down to these answer choices. And it didn't really help that much because we still have a shit ton of answer choices. But at least now we don't need to use that equation. So the goal here is, if you don't know the equation, if you don't have the equation ready, then just, if you know glucose and BUN are normal, then those are the only other osmoles we care about that are non-sodium osmoles that can worsen your sodium concentration. Our person's sodium concentration is not low because of another osmole, which means that our person's sodium concentration must be low because of water retention. There's no other way to think about it. Now, both of these answer choices are water retention, right? Inappropriate ADH secretion, which is SIADH, or a dilutional hyponatremia that caused the person to become very diluted with a lot of water, so that suppressed their ADH. A story that you can easily become convinced by and pick. He most likely has pneumocystis pneumonia, which was pretty obvious from his HIV and lung crackles. He initially has hyponatremia, and it worsens after receiving a large amount of normal saline over 2 days. The serum osmolality and ECF volume are important considerations in determining the etiology of hyponatremia. In him, low serum osmolality, which we can calculate by all this, but really just figure out logically that if his glucose is normal and BUN is normal, then his osmolality must be hypertonic. In the setting of euvolemia, because he has moist mucous membranes and no JVD. That's the other thing also. With mucous membranes are moist and no JVD. Because JVD occurs when you have a lot of volume retention. Everything backs up in the right heart. Mucous membranes become really dry if you're a hypotonic. They're ruling out everything. It's consistent with SIADH. Okay, low serum osmolality. How do you have low solute concentration, yet you're still having mucous membranes that are moist? SIADH. That's the only place. His pulmonary pathology is a common precipitant of SIADH, and patients with HIV are very prone to SIADH. Plus, ongoing receipt of normal saline can result in free water retention with ongoing sodium excretion that worsens hyponatremia. A dilutional hyponatremia with suppressed ADH is seen in psychogenic polydipsia, but he had no real reason to be diluted. He was being given normal saline, he's not drinking really crazy water or anything like that. Dilutional hyponatremia with suppressed ADH is a very valid answer choice, but not for him. Because although he could get dilutional hyponatremia, how is he diluted though? Where? because giving normal saline does not dilute a person. In normal saline, you're giving saline and other stuff with it. It's saline, not just water. Right? Saline is mixed with solutes in there. So this is a very good question. I love this question because it shows you how you could know the equation and solve this and do it a little quicker. Or you could do it even quicker if you just understand that the person's glucose and BUN are looking pretty normal. So those are not the other osmoles that are worsening the person's solute concentration. Right? So this person must be low serum osmolality. This person must be hypotonic. So always keep that in mind. You don't really need the equation, but I don't like saying that because then a lot of you are going to be like, all right, forget this equation. No, get the equation, memorize it, put it on the cheat sheet, get it down. You may need it for another question where they tell you some weird numbers. But all in all, an equation is a sentence, it's a paragraph, it's a statement, and it tells you if glucose is normal and BUN is normal and serum sodium is normal, then of course your serum osmolality is going to be normal, right? But in our patient, glucose was normal, BUN was normal, but serum sodium was low. So then, of course, serum osmolality will be low. That's all you're seeing here. Right? So this equation basically tells you, since it's all being added, it's a very easy equation, not multiplication, that these things are the three factors you care about in a hyponatremic patient to figure out their serum osmolality. All right. Very good stuff. Very good question. Takes care of all that. This table here is a full breakdown of things you care about for hyponatremia. We also revisited osmotic demyelination syndrome in neurology and got that down. That was very good. Always got to do that shock study of going back to old topics and anything you may not perfectly remember. We also visited acute kidney injury, understood pre-renal, intrinsic versus post-renal azotemia. That shouldn't be so confusing either. And just to wrap it up, the hyponatremia treatment is once again just based off of treating the underlying disorder, right? So hyponatremia is far more difficult than hypernatremia. Hypernatremia was easy. Fix the volume first, then fix the sodium. And fix the sodium over 3 days, not very quickly, otherwise you can cause these issues. Here also, you're going to fix things over 3 days. You're going to take 72 hours, maybe even more if necessary. But before that, we have a whole laundry list of issues that could be wrong in that person, and we need to focus on that issue, right? Because there's no point in fixing the sodium if you didn't fix the issue, because then the sodium is going to become bad again anyway. So treat the underlying disorder first, and then treat the hyponatremia from hypervolemic and euvolemic etiologies with water restriction, plus or minus diuretics. If the patient has low volume, then replete the volume first with normal saline. Right? If there's severe hyponatremia, consider 3% hypertonic saline, particularly if they're symptomatic. Correct chronic hyponatremia slowly, right? Using 8 to 10 milliequivalents per liter per day, right? Over 72 hours to prevent osmotic demyelination syndrome. Right? Osmotic demyelination. So we're looking at, remember from, there was the whole mnemonic, right? From low to high and high to low. So from low to high, your pons will die. From high to low, your whole brain will blow. Okay, this is low to high. If you go from low to high, your pons will die. You got osmotic demyelination syndrome, and you end up getting a person who's got full paralysis and can possibly be into a coma and die. And if you go from high to low, you're pulling water out. You're going to cause the brain to blow up because you're going to get cerebral edema, and the brain can herniate, and then the person once again goes into a coma and dies. So you have to fix it over 3 days. That's something, you know, I like saying it just like that. Fix it over 3 days. Take your time with it. The person is going to be hospitalized for a long time. Right? And the percentage of saline to give is the tricky answer choice. Right? We saw here in hypernatremia, you give normal isotonic 0.9% saline to first fix the volume. In hypernatremia, first you got to fix the volume, raise the volume, then fix the sodium. After that, once the normal volume has been achieved, you could use 0.45% NaCl or enteral fluids and fix their sodium levels, right? And total body water was a big player here with a very simple equation for total body water. In hyponatremia, where the sodium concentration is very low, it depends on how low, right? So I used 120 in all my examples, but if your patient's hyponatremia is even lower than 120, then you have to give them hypertonic saline. You have to give them some salt and water, right? So you have to fix both things. But if the person is hyponatremic because of other things, because they're either hypervolemic or they're euvolemic, like in SIADH, then you do water restriction, right? Give them water restriction and diuretics, get the water out of them, and then the dilution should go away and their sodium should become more normal looking. So you have to do a bunch of practice questions on all these things, have to make sure you understand how the topics look like, what is actually happening. Once you understand the pathophysiology of what is actually going wrong in the patient, it becomes a little easier to grasp what you're supposed to do. Now when it comes to potassium, potassium is not so bad, right? So normal potassium is 3.5 to 5. If your serum potassium is more than 5, it could be due to one of these few things. Spurious, what does this mean? So hemolysis of blood samples, fist clenching during blood draws, delays in sample analysis, extreme leukocytosis, thrombocytosis. Right? These are the etiologies are as follows. So this is one. The other one, decreased excretion, renal insufficiency, drugs that cause you to not excrete potassium, such as spironolactone is a potassium sparing diuretic, right? ACE inhibitors, trimethoprim, beta blockers. Remember, beta blockers also work on your insulin secretion, so it affects the pancreas. Hypoaldosteronism, where you don't have aldosterone. So if you don't have aldosterone, you're gonna lose sodium and retain potassium, right? When you do have aldosterone, you retain sodium and lose potassium. That's how they work. Type 4 renal tubular acidosis and calcineurin inhibitors. Calcineurin inhibitors were your cancer drugs in the immunology section in step 1 first aid. Cellular shifts. Cellular shifts of potassium are a big topic that we're taught in step 1. This is a step 1 topic, where cell lysis, rhabdomyolysis, tumor lysis syndrome, not having insulin, any case scenario of acidosis, and many drugs, exercise, which is a lactic acidosis, and resorption of blood like hematomas and GI bleeding. All of these are weird case scenarios where you can have a potassium shift that increases potassium in the serum. And then of course intake, eating things like bananas are high in potassium, right? So stuff like that. But the intake part, in sodium it didn't matter so much because you had a lot of hormones that are managing sodium. Here it matters a little more, but not that much here either, because there's really not a hormone that directly responds to how much potassium you have. Aldosterone doesn't care how much potassium is there. It's more so about the sodium. And there are some hormones that care about other things as well, right? Like for example, PTH cares about how much phosphorus is around, how much magnesium is around, but no one really cares about how much potassium is around. So what is the patient going to present with? Pretty weird symptoms. Maybe asymptomatic, which is the hardest part, but the patient may just present with nausea, vomiting, a little colic, loss of reflexes, some weakness, arrhythmias, paresthesia. You're going to be lost because you won't really be able to figure out what is actually wrong, right? What is actually causing this patient to kind of present in this manner, and it ends up being a little confusing over there. Diagnose, and you see they don't even mention any more stuff. That's all they wrote, which is why it's confusing, because these symptoms, none of them are specific to potassium, right? This can be happening in any kind of thing. How do you confirm the diagnosis? Well, confirm hyperkalemia with a repeat blood draw for suspected spurious results. So spurious basically meant it was out of the spurious by mistake, right? Something happened that made it look like the patient is hyperkalemic. So you want to make sure you don't fall for the wrong answer choice. If you collected labs and the person is looking like they're hyperkalemic, first things first, check again. Right? We naturally do this all the time, right? Check again. Because the patient may have done one of these things, like hand clenching and whatnot, that may have made it look like they're hyperkalemic even though they're not. Now, if you did the stuff and you found out they are looking hyperkalemic, the other things to do is ECG, to evaluate for cardiac complications. Because remember, hyperkalemia is one of the key things that can actually cause a person to get another fibrillation, right? ECG to evaluate for cardiac complications. ECG findings include tall peaked T waves that are almost as tall as the QRS, but I don't know if it would look like that. PR prolongation, which is that after the P starting the QR, this little segment here took a long time. And loss of P waves can progress to sine waves, ventricular dysrhythmias, and cardiac arrest. The sine wave is the most notorious one. In fact, what you start seeing in sine waves is really just something like that and something weird like that, and then just keeps happening, right? Which is exactly y equals sine x when you graph it on a calculator. So when you see a weird sine wave, that's a huge giveaway for hyperkalemia, probably really bad hyperkalemia. Treatment is listed in the mnemonic C big K and is summarized as follows. Right, so C big K: calcium chloride gluconate, bicarbonate, insulin plus glucose, or kayexalate, which is really never written as kayexalate. They just made it like that so that it would fit this C big K mnemonic. It's usually just going to be written as sodium polystyrene sulfonate. So calcium gluconate is the most common answer choice that I've seen. And what you use, it's not like you can use any one of these. What you use really depends on what's causing the hyperkalemia. Best initial treatment, always give calcium gluconate, which is what I just said is the most common answer choice, right? It's the easiest thing you can just pick, even if you don't know what's actually wrong. Calcium gluconate will go to the cardiac cells and cause membrane stabilization, especially if potassium is more than 6.5, which is super high, right? So calcium gluconate would save their life, basically. Give insulin with glucose to avoid hypoglycemia. Why? Because insulin causes a potassium shift into the cell. It was the mechanism of action of insulin. That's how it works. So even though this person may not be diabetic, we would pick this answer choice, which is what makes this a confusing answer choice, because many students are not going to want to pick it. You're going to be like, why am I giving insulin to this patient who is not diabetic, probably has a normal glucose level in their labs? You have to. The point you're giving insulin in this person is not for their sugar, is to cause a potassium shift into cells. Right now their potassium is outside, it's in the serum. You want to move all the potassium inside the cell. Insulin will do that, but you give sugar with it so that they don't become hypoglycemic. You want to give a beta agonist like albuterol. Why? Because remember from way back here, that one of the pages you should have bookmarked, printed, or something so you can look at it every day, is this list of receptors. And you remember the things I underlined right here, right? So you see how beta 2 agonism will increase insulin release. And a person who is taking a beta 2 antagonist, a beta 2 blocker, will decrease insulin release, right? Which is why metoprolol is something you can use to help people depending on what's happening, right? Because although you would stop insulin release or increase insulin release, it really depends on what else is wrong with the person, right? But you see how beta 2 agonism even increases cellular uptake. Intracellular potassium shift via stimulation of sodium potassium ATPase. Beta 2 insulin release further exacerbates this intracellular potassium shift, which is exactly what you need in a person with hyperkalemia, right? So we want to give that beta 2 agonist, not just a beta agonist, so beta 2 agonist, and or alkali like bicarbonate to temporarily shift potassium into cells. Most rapid way to shift potassium into cells, literally. So if you get a person with hyperkalemia, that's dangerous. They can die of a heart attack, right? Quickly give them calcium gluconate. Once they're stable, give them insulin and sugar, and then put them on a beta agonist, and they'll be alright. Eliminate potassium from the diet as necessary. Penicillin has potassium on it too, so this would be a very tricky and bullshit question if you ever get a patient who took penicillin and now they're presenting with hyperkalemia symptoms. Remove potassium from the body. Historically, kayexalate, which is sodium polystyrene sulfonate, has been used to remove potassium from the body. However, it was historically used. In today's time, this is rarely found anywhere, and is contraindicated in patients who have ileus, bowel obstruction, ischemic gut, or pancreatic transplant. But remember, a person who's getting hyperkalemia probably has one of these problems, right? You don't just get hyperkalemia out of nowhere as a healthy individual. So if you can't give this to unhealthy individuals, what's the point of such a medication you can't give to unhealthy individuals? It's not really that good. But of course, on your exam, it might still be an answer choice. Because of serious adverse effects, kayexalate is falling out of favor. IV saline and loop diuretics can enhance urinary excretion of potassium. So now you might get a patient who's got a lot of fluid retention and hyperkalemia. Put them on a non-potassium sparing diuretic. Non-potassium. You don't want to put them on a potassium sparing diuretic because then that'll beat the purpose and probably worsen things. Give them a diuretic that would get rid of potassium also, right? So this means you go back to your step 1 first aid renal farm section, and we just covered that in the step 1 course. I think it was yesterday we just talked about it. But not even renal farm. The best place to actually learn how it works is the renal physiology section, where they have the nephron and they tell you what each segment of the nephron does, right? And you get to see what in each segment you have its own group of medications that work. Where PCT has the most things, thick ascending limb has just the loop diuretics, and you can see how you would stop all this potassium from coming back in if you take loop diuretics. The DCT has thiazide diuretics, which really don't do much to potassium at all, so that's not the right answer choice, right? And then in the collecting duct, you have amiloride, trimethoprim, and spironolactone, which are not the guys you want to pick because those are basically kind of sort of potassium sparing. So you don't want to do spironolactone. You don't want to do a potassium sparing thing, right? You want to get rid of potassium. So you can see the best way is to use loop diuretics, stop the potassium reabsorption over here, right? And all of these has other side effects that you need to worry about when you study that section. But you see how this is nice and easy. You don't have to calculate anything. You don't have to worry about anything. It's very easy. Person has hyperkalemia, give them sodium gluconate to save their heart, give them insulin and sugar to move the potassium into their cells, get rid of some potassium in their urine by giving them furosemide, and you're done. All right. In really, really bad case scenarios, dialysis is needed, especially if the patient has renal failure, right? Because then you can't use furosemide to depend on their kidney to actually urinate potassium, right? So you have to give them a fake kidney, basically dialysis, and get rid of it. Next case scenario, hypokalemia. So this is a serum potassium of less than 3.6. I just like to say 3.5 to 5 is normal. So transcellular shifts or GI losses. How can you get low potassium? Well, if a person takes too much of some of the things we just tried using to fix hyperkalemia, then you get hypokalemia, such as taking too much insulin. You would move all your potassium into the cell, and now you're going to look hypokalemic. Taking too many beta-2 agonists, once again, you're going to cause too much insulin secretion and also an active potassium shift into cells. And also alkalosis. We just saw, and this is taught in step 1, we just saw that the list of things that causes you to have too much potassium were a bunch of different things that could cause acidosis, right? Like renal tubular acidosis, even really intense exercise, which also causes lactic acidosis, right? Hematomas and GI bleeding are also an acidotic state because you would also have lactate dehydrogenase activity there as well. Acidosis in general, all acidotic things cause hyperkalemia. Because when you think of acid, you should think of someone having a lot of H+. So H+ and K+ go together, right? We talked about this. We talked about it, and I love going back to this thing every time because I kind of created it and it's something I'm really proud of, which is this, right? K+ and H+ always travel together in the electrolyte world of discussions, basically, right? So if your person has a lot of acidosis, there's going to be hyperkalemia. It just is how things work, right? The opposite is also true, as I said. So here, alkalosis causes a potassium to shift into cells. So you're going to have low potassium in patients with alkalosis problems. A person can also have low potassium because of GI loss, right? You could have someone who has diarrhea, chronic laxative abuse, vomiting, nasogastric tube suction. All of these people are going to lose a lot of potassium along with a bunch of other stuff. And then the last one, renal losses. Someone who's taking diuretics like furosemide would also lose potassium, just like we used furosemide to make a person lose potassium when they have hyperpotassium. Primary mineralocorticoid excess or secondary hypoaldosteronism, decreased circulating volume, Bartter and Gittleman syndrome, diabetic ketoacidosis, hypomagnesemia, and type 1 and 2 RTA, renal tubular acidosis. You need to go back and memorize Bartter, Gittleman, Little. We talked about some of this in the step 1 course yesterday. And then type 1 and type 2 and the other renal tubular acidosis problems and what they do. And this is stuff you don't memorize as a one-to-one association with the disease name. You memorize it based off of the nephron physiology. If you know what part of the nephron it affects, you should know what's not working, right? So that's something that you have to spend time on for sure to understand and better remember all these electrolyte abnormalities. Patients present with fatigue, muscle weakness or cramps, ileus, hyporeflexia, paresthesias, rhabdomyolysis, and ascending paralysis. Once again, just like in hyperkalemia, hypokalemia also presents with really vague, useless symptoms that don't help. Okay, but hopefully the question will just tell you labs, and you'll see that the potassium is low. Otherwise, the most simple way to think about it is if you think of all the things that are supposed to cause hypokalemia, just like you're supposed to think of all the things that caused hyperkalemia. To keep it simple, let's just look at like acidosis versus alkalosis, right? Acidosis causes hyperkalemia. So if we go back to hyperkalemia, acidosis causes hyperkalemia. If you think of what acidosis would cause, then you would somewhat think of some of these issues. A person who has a lot of acidosis may have some of these issues. And that part doesn't really fit too well, but the alkalosis part fits really well. If a person is having a lot of alkalosis, right, that means they have a lot of bicarb in them. That means that they're not really having a lot of CO2 retention. They've lost CO2, right? Those are some things that are worth remembering for this presentation. Because if you get a question where they didn't give you the labs, and you're supposed to figure out that it's hypokalemia without lab values, it's going to be pretty hard, right? Because none of these symptoms are really that specific to, I don't see muscle weakness and instantly think, oh, hypokalemia, right? But now you have to start associating that. Muscle weakness has to be associated with hypokalemia. Rhabdomyolysis has to be associated with hypokalemia. But there's going to be other tricky answer choices in there too, like statin therapy. Statin therapy is not what you pick if that's not what's actually happening. So pay attention to what else is wrong with the patient to rule out wrong answer choices, right? Because these symptoms are not very specific, right? But you just have to, if you see potassium or hypokalemia related stuff as answer choices, you need to revisit the question and reevaluate how possible that is, right? Workup is pretty similar to hyperkalemia. You do the ECG. You see the opposite now. In hyperkalemia, you saw really tall T waves. In hypokalemia, you're going to see very flat T waves. Right? Treat the underlying disorder. Give them potassium. You can actually feed people potassium, right? So just feed them the potassium they need. Oral is the preferred route for safety purposes. If IV is necessary, a continuous rate of potassium as an additive is preferred over an IV potassium bolus. Don't do this. Reserve IV boluses for symptomatic hypokalemia or ECG changes. Do not exceed 20 milliequivalents per liter per hour. Replace magnesium also, as this deficiency makes potassium repletion more difficult. Right, so they should not be magnesium deficient when you're trying to fix their potassium deficiency. Right. So let's take a look at these two questions over here. 58-year-old man with Burkitt lymphoma is admitted to the hospital for chemotherapy. Medical history includes hypertension, stable angina, and hyperlipidemia. 2 days after starting chemotherapy, he reports nausea and generalized weakness. Labs show you normal sodium, high potassium, everything else looking pretty good. Their kidney's not good. Glucose high, right? So you're seeing these three things are bad. ECG shows peaked T waves, which is typical of hyperkalemia. Right, so this is one way they might tell you the person has hyperkalemia if they didn't give you labs, right? Peak T waves, you should think of hyperkalemia as well. Whereas in here, what you're seeing are T waves that are flat, right? Hypokalemia. Right, so you have prominent U wave indicated by this arrow, prominent U wave, but also if you look at the T wave that's supposed to occur in some of these is becoming pretty flat, right? So the T wave is not as tall as your QRSs are, right? But again, it really depends on what you can focus on. In V1 through V6, and this is showing you the right half of your this is half of your ECG. Remember, you cut it down in half, right? Over here would be your 2, 3 AVF and all that stuff. This is just showing you the right half. When you look at the right half of an ECG, we discussed this in the beginning in cardiovascular, that you're supposed to look for something called the R wave progression. And we are definitely not seeing R wave progression here, right? Because in the beginning it was supposed to be small, then it was supposed to get bigger, and then it was supposed to come to the top rather than being at the bottom. And it did come to the top, but it's still just huge all around. These are really tall R waves all around. So that's something that's already concerning. And then there wasn't supposed to be this bump that constantly shows up pretty much everywhere. So this ECG is focusing really on just showing you the prominent U waves. But and this is also considered an inverted T wave, right? Because it's the opposite direction of the QRS. You have your QRS, but then you're supposed to have a T wave. It's the other way around, right? And only in this place right here does it really look flat, this one and this one, but the others not so much. Right? So either way, The ECG stuff could be one way they kind of get you to make you depend on the ECG to figure out hyper versus hypokalemia. But here they're doing a good job with both things. All right. What intervention should be employed next to rapidly lower serum potassium in this patient? Now, we know multiple ways to rapidly lower serum potassium. We just looked at it. Calcium gluconate, the beta 2 agonist, the insulin and sugar, right? And then furosemide, make them urinated. Not always, right? Not all of those directions of doing that are great for everyone. So when they say it's in this patient, you have to consider what would be the best thing to do for this 58-year-old man who has cancer and getting chemotherapy, right? So for him, the answer was insulin and glucose, which you could see, most people picked, but look at what the other answer choices are that a lot of other people picked also. And of course, that happened because they remembered it. It's good that they remembered it, calcium carbonate, but this is not exactly what we were supposed to remember, right? Why would you pick calcium carbonate? Remember what it was? Calcium gluconate, right? You see how they did like a bullshit thing in that answer choice to really confuse you? First of all, giving calcium gluconate would, although it would help, remember here, always give calcium gluconate for cardiac cell membrane stabilization. Nowhere did it really say though that calcium gluconate would lower the hyperkalemia, right? That's not what it does. Correct answer here was just to give insulin and glucose. Why? Because giving insulin and glucose is like giving a positive and a minus and just letting them cancel each other out. They will cancel each other out in terms of glycemia levels. It won't cause hypoglycemia in him, but it would also fix the potassium by shifting the potassium into cells. Now, if you further look at the fact that his glucose is high, it actually even means more the reason to give him insulin. It would help, right? This patient with Burkitt lymphoma has hyperkalemia, likely due to tumor lysis syndrome from the chemotherapy. Indications for emergent treatment of hyperkalemia include presence of hyperkalemia-related ECG changes or marked elevation or rapid rise in serum potassium level. Hyperkalemia is life-threatening due to its adverse cardiac effects, including significant bradycardia and arrhythmias. Goals of treatment include stabilizing the cardiac membrane, lowering serum potassium by shifting potassium intracellularly, and lowering total body potassium. Serum potassium may be lowered faster by stimulating an intracellular potassium shift rather than by removing potassium from the body using furosemide. IV insulin can move potassium intracellularly within minutes. Glucose is given along with insulin to avoid hypoglycemia. Calcium chloride or gluconate can help cardiac membranes, but not calcium carbonate, which is an oral calcium supplement and just a tricky answer choice, right? And hemodialysis would be key in renal failure. Now, even if this answer choice was calcium gluconate, it would still be the wrong answer choice because the question is asking you how can you rapidly lower serum potassium, and calcium gluconate does not lower serum potassium. It would be something you give to the patient to help his heart, but the question, always answer the question. What are they asking you? They're asking you how would you lower the serum potassium. You would lower it with insulin and glucose. The other way to lower it is furosemide, but you may not want to give him furosemide, right? Because he's kind of elderly, he's going through chemotherapy. If you give him furosemide and he loses a lot of fluid, he might become worse, right? So that is something you want to keep in mind. And sometimes patients may have other contraindications for why you can't pick one answer over the other, even though both are valid answer choices. Right? So you have to be aware of those things. Here, 55-year-old man comes to the ED due to progressively worsening shortness of breath for the past 3 days. He also reports wheezing and productive cough with purulent sputum. Medical history includes chronic bronchitis and BPH. He smokes a pack daily. Vitals show you high blood pressure. Pulse ox shows 84%, which is bad, so his lungs are not causing good air exchange for some reason. He is alert and answering questions coherently. Exam shows decreased breath sounds and diffuse wheezing over all lung fields. Okay. He's admitted to the hospital and started on antibiotics, systemic corticosteroids, and nebulized albuterol, as well as ipratropium, because he may have COPD. The following day, lab results are as follows. Serum chemistry, potassium is extremely shitty low, BUN 28, creatinine 1.1. Serum chemistry 2 days ago was normal. What is the most likely cause of his low serum potassium? How did his potassium become so low? Right? What caused him to lose all his serum potassium? So you look at all your answer choices and you pick the one that tells you the most logical reason that maybe caused him to lose his potassium. So 75% of people got it right. Increased beta-adrenergic activity, because you know beta-2 activity, which was possible from all the medications he's getting and stuff. That increased beta-2 activity not only increases insulin, which would of course cause a potassium shift into cells, but it also actively itself causes a potassium shift into cells. So that's two reasons. Other people chose decrease in extracellular pH. So decrease in pH is acidosis. So if you have acidosis, right, that means that you would have a lot of H plus in your serum. H plus and K plus go together, so then you would have hyperkalemia. Right, so that's the wrong answer choice, right? If the answer choice said increase in extracellular pH, which is alkalosis, then at least that would be a reason to have hypokalemia. But then you would still have to wonder, why would he have alkalosis, right? And if he has a reason to have alkalosis, then maybe it would be the correct answer choice, but he doesn't have a reason to be alkalosis. Low serum potassium may result from increased potassium entry into cells, renal potassium wasting, or GI fluid loss. He has acute COPD exacerbation, being treated with beta-2 agent albuterol. Exogenous and endogenous beta agonists cause a potassium shift into the intracellular space by stimulating the sodium-potassium ATPase and the sodium-potassium dichloride cotransporter, as well as stimulating release of insulin. Right, so in this question explanation, they're giving you three different ways beta-2 agonism causes potassium to shift into cells, which is why giving insulin and sugar is such an amazing route to fixing hyperkalemia. Right, so this question up here was hyperkalemia. This one down here is a hypokalemic patient. And that's all you have to do. Just pick what caused it. Do you have to do anything to fix him? Yeah, you should probably just give him potassium. That's really all you have to do to fix him. You don't have to do anything else. Don't worry about it. Also, doesn't require potassium to be given over 3 days, right? Only sodium is very complicated. Potassium is very simple, right? With potassium, we can just give the guy a banana, maybe add a little potassium into his IV line, but generally speaking, he'll be okay. Especially if his ECG is okay. The next best step will be to check his ECG because of this hypokalemia to see if it's affected his heart yet. If his heart is okay, then you can easily maintain him and just get him better. If his heart is getting messed up, then you have to treat him more quickly, right? So always remember, best next step, workup, ECG. Last question over here. A 54-year-old woman presents to your office complaining of difficulty walking. She describes severe weakness and occasional pain in her thigh muscles. She has stumbled and fallen several times over the last week. Past medical history is significant hypertension, treated with ACTZ and metoprolol. She consumes 2 to 3 cans of beer on weekends. Her younger brother died of neurological disease at age 20, and her mom suffers from hypertension and diabetes. Her heart rate equals 90 and blood pressure is super high. Chest exam is normal. A bruit is heard over the left carotid artery. So she has carotid artery atheroembolism, possibly a lot of atherosclerosis of the, not embolism, just atherosclerosis of the carotid artery is causing the bruit on that left carotid artery. But understand that if she has a bruit here in the left carotid artery, then she must have really bad atherosclerosis overall in other parts of her body also. Neurologic exam reveals hyporeflexia and decreased strength in all muscle groups. Her ESR is 12. ECG shows flat and broad T waves. Right, so flat T waves are a sign of hypokalemia, right? Whereas very tall T waves are hyperkalemia. Occasional premature ventricular contractions as well. Right, so she's got some PVCs happening. What's the most likely responsible? I mean, why would you think she has ALS? For ALS, you have to understand that you're looking for a person who's having primary symptom is going to be they can't swallow things well. It's usually bulbophageal symptoms. Can't eat well, can't really drink well. And then they also have upper and lower motor neuron deficits, but their bladder stuff works fine. ALS, straight up, the person's going to die. Can't do anything about it, right? Inflammatory myopathy. Well, ESR is 12. This is not inflammatory. Right? ESR more than 20 is where you start kind of sort of thinking it's inflammatory, but 12 is not inflammatory. That's not inflammation, right? Would have a higher ESR and maybe even secreting kinase if it was that. Those answer choices didn't make sense. The ECG findings, ECGs are always related to sodium, potassium, and calcium, right? Those are the things we looked at when we learned about ECGs. The whole QRS was related to your nodal function and the ventricular myocyte function and how each part meant a different kind of electrolyte. That's what we're seeing here. And if the T wave is normal, that's normal potassium. As soon as it's too tall, is too much potassium. And if your T wave is flat and broad, then you have low potassium. This patient is presenting with weird cardiac symptoms simply because of potential hypokalemia. Right? She's taking a potassium wasting hydrochlorothiazide, which is the most likely cause of her hypokalemia. You cannot depend on any history of physical exam, any of those things, history or physical exam, for figuring out hyper versus hypokalemia. You have to use your own clinical knowledge and clinical judgment to evaluate that this patient must be hypokalemic, right? And then last few things. So let's wrap this up. Let's do it. Next thing, hypercalcemia. Also pretty easy, not so bad at all. This was mainly related to our endocrine topic of PTH, hyperparathyroidism. Serum calcium more than 10. I just think of it as simpler numbers. Don't worry about 10.2. You're not going to get a question where a person has 10.3 calcium and you were supposed to be like, oh my god, they're hypercalcemic. No. So just work with 10, right? 10. Calcium more than 10, hypercalcemic. And you have to correct it for serum albumin, which slightly complex, but not as bad as the whole sodium thing was. But serum calcium more than 10, the most common causes are the following. First of all, of course, hyperparathyroidism. So what are you going to see in hyperparathyroidism? Well, PTH is also a phosphate trashing hormone. So if their issue is due to PTH, they should have low phosphate also, right? If you don't see low phosphate, then the answer is not due to hyperparathyroidism. It doesn't make sense, right? Could be malignancy, breast cancer, squamous cell carcinoma, multiple myeloma. A lot of cancers just naturally cause an elevation in serum calcium. Other causes are summarized in the mnemonic chimpanzees that you're never really going to remember, but you should know most of these things in here. So of course, someone who's eating a lot of calcium is going to have hypercalcemia, hyperparathyroidism, hypothyroidism, iatrogenic things, milk alkali syndrome. This is usually going to be a person who's taking one very specific thing. So you're going to get a question about a person who started taking antacids because of their heartburn, and the one they're taking is this one, calcium carbonate. If they're taking calcium carbonate, they get hypercalcemia, which causes milk alkali syndrome. That's it. Aluminum hydroxide and magnesium hydroxide are both hydroxides that are really easy to remember. Aluminum causes minimum amount of feces. You actually get a patient who ends up getting constipation, right? And then I came up with my own little thing for memorizing the rest of what this does. So the A is the first letter in aluminum. So it's the head of the alphabet. So the A reminds me of seizures. The L is like your vertical spine. So you get osteodystrophy, right? And the U is like flexing your hand. When you flex your arm, you make a U sign with your body, and that's your muscle not having enough strength to it. Again, you don't really need to know this that well. It's just a shock revision. The more you know, the better, right? There's no knowledge that goes wasted. So aluminum hydroxide, you get minimum amount of feces with constipation. You get issues with your bone, seizures, and muscle. In magnesium hydroxide, that's a magnum antacid. It really makes you go, so you get diarrhea, right? These are antacids. They're not supposed to affect how much you poop. It's just supposed to go help you with your heartburn. But unfortunately, they do affect how much fecal matter you can get out. So aluminum hydroxide causes constipation. Magnesium hydroxide makes you really go have diarrhea. And also it reminds you of magnesium, right? So you kind of have magnesium in here, which causes excess magnesium effects. So think of the M as the M protein of our heart. Same M protein where strep pyogenes causes cross-reactivity. So in here you get cardiac arrest, which could be dangerous. So no one really tends to use aluminum hydroxide or magnesium hydroxide. Most antacids just have calcium carbonate. If you get a patient who's been taking antacids and now they're presenting with hypercalcemia symptoms, you think of milk alkali syndrome. Paget disease, because you have excess bone remodeling. Neoplasm we looked at, Zoninger-Elson. Excess vitamin A or D, I've never really seen this as a question. Sarcoidosis, yes, because you have a lot of vitamin D in any granulomatous disease. Right? Granulomas have macrophages. Macrophages upregulate vitamin D formation, which then leads to upregulation of calcium, right? A lot of calcium. So a bunch of things that can possibly cause hypercalcemia. In your question, they may mention maybe one or two of these things, and if you see the patient has hypercalcemia, I can't figure out any reason they have the hypercalcemia, you just pick whatever they mention. You know, it could be the excess vitamin A as the answer in that question. How does hypercalcemia present? Well, they right here is usually asymptomatic, but it actually isn't. This was the whole, do they have the mnemonic written here? This was the whole stones, bones, groans, that mnemonic. Let's go back and look at it real quick. Right here. All right, so usually due to parathyroid adenoma, which is hyperparathyroidism, but what does hypercalcemia cause? So hypercalcemia causes hypercalciuria, first of all. Remember we talked about in another video about this disease, familial hypocalciuric hypercalcemia, where you have a lot of calcium in your body, but you're not urinating a lot of it. That was just a defect in the calcium sensing receptor, where your body doesn't realize how much calcium it has. Okay. Here though, and in all other cases of hypercalcemia, you get hypercalciuria also. So you urinate a lot of calcium, which causes the stones. You also just end up urinating a lot in general because of the high electrolyte counts. So polyuria, stones, thrones, throne is your toilet. Groans because of constipation, and psychiatric overtones because you will have mental status changes in these patients. Right, so stones, thrones, bones, groans, and psychiatric overtones. A bunch of things that happen. The bones part is rare in just straight hypercalcemia. The bones part is more so related to primary hyperparathyroidism. Right? Just hypercalcemia won't cause osteitis fibrosa cystica, which is cystic bone spaces filled with brown tissue. Right? That's something more so related to primary hyperparathyroidism. Right? So that's what they're describing here. It can present with bones, osteopenia, fractures because of the cystic bones, stones in the kidney, abdominal groans because of constipation, and psychiatric overtones with irritability and altered mental status. Best initial test: total calcium, albumin, phosphate, PTH. Definitely PTH. Also electrolytes, BUN, creatinine, magnesium, and alkaline phosphatase levels, just to see where else is there a problem. Consider PTH related peptide if malignancy is suspected, like maybe the patient has a long 35-pack year or 40-pack year smoking history, sudden coughing, non-productive cough, and then maybe they even tell you there's a mass in the left lung or something. Right, it could be in either lung. Then that's someone who has squamous cell carcinoma of the lung with PTH relating release of PTH related peptide, which acts like PTH. Right. Any kind of granulomatous disease will have excess vitamin D. Right, so all of that stuff. And then lastly, you could order an ECG because calcium was part of the ECG as well, and you may see a prolonged QT interval. So why prolonged QT interval? That's because the calcium, so if we go back to one of those diagrams a lot of you probably really didn't enjoy. Let's see. Right here. Right, so you see how in both, this is the nodal one. In the nodal one, clearly calcium had a role, and then also in your myocardial action potential, calcium had a role, right? In the myocardial action potential, calcium was part of the plateau, phase 2, where you had calcium and potassium movement at the same time, so it kind of stabilized for 0.02 seconds, right? 200 milliseconds is the whole thing. And here, calcium was part of phase 0, which actually caused you to have depolarizations, right? The nodal depolarizations. So, of course, with the nodal depolarization itself not working very well, well, we're looking at hypercalcemia, this is working too well, so you get prolonged QT interval. If serum calcium is more than 14, so more than 10 was already a problem, but if it's so high that it's more than 14, you need to treat it urgently with isotonic fluids like furosemide and calcitonin. Bisphosphates like zoledronic acid or permethrinate should be considered as well, because bisphosphonates are the guys that are going to stop you from kind of having more bone remodeling. A high sodium intake in isotonic fluids facilitates renal calcium excretion and prevents renal complications like stones. Right, in general, they should be drinking a lot of water anyway, because that way they'll prevent formation of calcium stones in their ureter, and treat whatever is the underlying disorder, including steroids for some of the granulomatous diseases. But it's not so bad. This is actually pretty straightforward and easy to work with. Just fix the calcium problem. Right? Sodium is the hardest one. Hypocalcemia. So now you have someone who has a calcium of less than 8.5. But again, for calcium, I just memorized 8 to 10. Right? Just 8 to 10 is normal. Parathyroid related. So if they have hypoparathyroidism, maybe because they had a thyroidectomy and they got their parathyroids removed by mistake as well. It could be secondary hyperparathyroidism, which is basically chronic kidney disease, and pseudo hypoparathyroidism. In infants, considered DeJour syndrome. Right? Malnutrition, vitamin D deficiency. Other things could be hypomagnesemia, acute pancreatitis, or chelation from citrate in blood products. This one is actually a pretty nice question they love. Right, so blood products, especially blood products that have been sitting for a long time in the hospital, often have a lot of citrate in them to keep the blood product alive. But the citrate can actually cause chelation with the calcium and make you lose calcium upon being given a blood transfusion. So that might be happening in a question. Loop diuretics lose calcium, thiazide diuretics reabsorb calcium, so you want to make sure for hypocalcemic patients you don't put them on a loop diuretic. Give them a thiazide diuretic if they need a diuretic. Right? Presents with abdominal muscle cramps, dyspnea, tetany being a key one. Possible convulsions. Basically, you won't see the stones, bones, groans thing. That's the hypercalcemia stuff. But you don't necessarily see the exact opposite either. Right? Facial spasm elicited from tapping on the facial nerve, and carpal spasm on the arterial occlusion by a BP cuff are classic findings. And that's what you'll see. Tetany plus the Schwastek or Trousseau sign. Right? When they describe these things, then you start thinking, oh wow, you must be hypocalcemic. How do you fix this? Well, first of all, how do you test for this? Check for how much calcium and PTH they have. Right? You always need to worry about PTH when you're dealing with calcium-related problems. If the patient has had a thyroidectomy, review the operative note to determine if there was any potential damage to the parathyroid glands. Check for magnesium, because if you have extremely low levels of magnesium, then you can have PTH resistance. Albumin, 25 hydroxy vitamin D, 125 hydroxy vitamin D. You need to see if they've been taking too much vitamin D or if they're making a lot of vitamin D in some granuloma. You also check for all the other typical things, BUN, creatinine, alkaline phosphatase, and of course do the ECG. And so back here when we were in endocrine, we saw with PTH that if you have extremely low magnesium, you end up having bad PTH function. Right? So hypomagnesemia, which we're also going to see, is heavily related to PTH function. How do you fix this? Just treat whatever's causing it. Right? Treat whatever's causing it. In most cases, we'll need to administer oral calcium supplements, give oral IV calcium for severe symptoms, ensure magnesium is also repleted. In both case scenarios, we saw that, in a lot of these case scenarios, we saw that magnesium needed to be given. So here in hypocalcemia, give magnesium was important, right? And then right here too, right? In hypokalemia, replace magnesium here as well. Right? So the hypo things, if you have low potassium and low calcium, give magnesium as well. So let's look at some of these questions now. So we have 57-year-old homeless man with known HIV comes to the ED complaining of shortness of breath and non-productive cough over the past week. History of diabetes, poor follow-up, medication compliance, sucks. CD4 was really low. Alright, so he's pretty bad. Today he's infected. Oxygen saturation is low because his lungs not working that well. Lung exam is showing you rales. Abdomen is soft and non-tender. Potassium is looking normal. That's normal, between 3.5 to 5. Chest X-ray shows bilateral patchy opacities in the lower lungs. Treated with azithromycin, ceftriaxone, TMP, prednisone, and albuterol. Oof. He's also given insulin. Okay, so he's treated with a bunch of things. So I'm just going to underline that. All those medications and insulin before meals because he's diabetic. Okay. On the third day of hospitalization, his serum potassium is super high. And his creatinine is 1.5. What medication is most likely responsible for these lab changes? Now only 40% got this right, of which a lot of these people may have guessed. 15% of people chose albuterol. Remember what albuterol did? It was a beta-2 agonist. This is what you would actually give him to fix this. Albuterol moves potassium into cells. So how could albuterol be the one that increases potassium? Wrong. Azithro and then prednisone. Okay. Prednisone is just a corticosteroid. It's not really going to do anything to your electrolytes per se. So this 20% of people picking it was pretty interesting. So you're left between two antibiotics and you may not know what they do. Well, this one is a sulfa drug, right? TMP and SMX work sequentially to block bacterial synthesis of THF. TMP SMX is commonly used for treating uncomplicated UTIs, pneumocystis jirovecii, which he may have, community-acquired MRSA skin infections, and nocardiosis. TMP, trimethoprim, can cause hyperkalemia by blocking the epithelial sodium channels in the collecting tubule, similar to the action of the potassium-sparing diuretic amiloride. This occurs more commonly in HIV patients who are treated with high doses of TMP, but even normal doses can produce a modest elevation in the plasma potassium concentration. Thus, patients treated with TMP require serial monitoring of potassium to avoid serious complications. TMP also competitively inhibits renal tubule creatinine secretion and may cause an artificial increase in serum creatinine, but GFR remains unchanged. Now, did you need to remember that TMP causes a direct effect on potassium? Not really, no. What you needed to remember was that TMP does cause an effect on the kidney, and once you had that down, you could just assume that that must be the reason their potassium is so high, right? So here they tell you for sulfonamides, especially for trimethoprim itself, right, it causes hyperkalemia in high doses. They specifically tell you that, right? But in all general honesty, you may not memorize this, and you don't really need to. As long as you can have some recall of things, that's all you really need. And as far as I know, I remember azithromycin and all your macrolides. I remember this better than TMP. And my macrolides, for the number one thing that I know about them, they can cause slowing down of gut motility, but nothing to do with electrolytes. So I have no reason to pick that either. And I would just go with TMP, even if I don't really remember it, right? Even if I don't really remember it. But TMP does have some other weird things it does, right? It causes leukopenia, granulocytopenia, causes a bunch of weird effects, right? And sulfonamides, these guys, their adverse effects cause nephrotoxicity. So another way to indirectly get that question right, which is how I actually answered it right the first time I did it with a student, was that I thought, okay, TMP SMX, maybe the sulfa part, that's causing nephrotoxicity, and that's why his kidney's not working well, hence the creatinine change, and that's why he has hyperkalemia, right? He just can't get rid of potassium very well. Either way, you would pick this answer choice and you would move on, right? Not the other guys. There was really not much to them that should ring a bell. Here's a little list of medications that can actually cause hyperkalemia. It's all here now. Notoriously, everyone knows digitalis can cause hyperkalemia, which is a bad prognosis. You need to discontinue the digitalis right away. But the others, you just spend some time and you get it. I would say that the most important ones that most people don't tend to remember are the ACE inhibitors here and the NSAIDs. No one really tends to remember that they actually cause an increase in potassium. No one knows this either. Very few students tend to remember that heparin actually blocks aldosterone production, which can also cause hyperkalemia. Almost no one ever knows that. Most people don't even remember what heparin itself does correctly, right? Heparin also blocks aldosterone production, which you may not have known, right? Because it's not notoriously spoken about, nor is it really mentioned anywhere. You just apparently are supposed to know this, right? So you spend time repeating those things more than other things, and you'll get it down. Right? Cyclosporin was one of your calcineurin inhibitors, so that's what's over there. This question was a really easy question about a young woman who was lightheaded, lost a lot of weight. She's missing her periods now. Blood pressure is extremely low, and then they do her serum chemistry, and sodium is looking on the lower end. Potassium is very low, right? Urine electrolytes show high sodium in the urine, high potassium in the urine. So what's happening here, right? How could you be losing all this in your urine? Well, the only way to do that is with medication abuse, diuretic abuse. That's it. Right? This is a person who probably has, as you guessed, some kind of anorexia or bulimia kind of problem. Right? In this question here, 33-year-old woman brought to the ED after an episode of generalized tonic-clonic seizures. She's confused and unable to provide further history. Review of the medical records indicates that she has schizophrenia, right? So she's got some kind of psychosis. But she stopped taking all her psych medications 3 weeks ago because of whatever. Pupils are normal, lungs are fine, abdomen is okay. And then they do her labs and sodium's extremely low. Potassium's also looking low. Calcium is coming down towards the lower end. Alright. Serum osmolality. So serum solute concentration is low, right, which is a little weird. Urine osmolality These numbers, I must have written something wrong here. 78 doesn't really make sense. This is probably like 278 maybe. I'm not sure. Might not be a trustworthy question anymore. But either way, what do you do with this kind of a patient? What's the most likely cause of electrolyte abnormality? Okay, so if your urine osmolality is actually higher than serum osmolality, well, let's assume it is, then the urine concentration will be higher than the serum concentration of things, and her serum is really diluted, basically. In general, even though there's some kind of typing error here in this question, which I think I just fixed with the 278. Either way, if you have a patient who's got some kind of psychotic problem, and now they're presenting with multiple electrolytes being low, then it's probably a person with primary polydipsia. As I said, you can always remember that antipsychotic medications cause thirst. And these patients end up drinking water nonstop because they're just psychotic and they're drinking a lot of water for their thirst, but then more than they needed to. And that just causes a dilutional effect of diluting multiple electrolytes. That's it. Okay. And this we already talked about, the evaluation of hyponatremia. This table is a kind of toned down, easier looking version of our hyponatremia table in first aid. But the first aid hyponatremia table is very important for actually being able to know everything you need to know. This here is showing you how calcium is affected by acid-base shifts. Acid-base shifts, as we saw, also affect potassium. We said that potassium and H go together. So every time you have high H+, which is a low pH, you have a very acidic pH. You also have high potassium. And here it's a little different. So when a person has acidosis, all that H+ attaches to albumin and it increases calcium. Right? Although the same thing is happening, high H+ equals high calcium, the mechanism is a little different. When a person has low pH, there's only one H+ to attach to albumin, so instead of H+, a bunch of calcium gets attached to albumin, causes low calcium. Right? This isn't so hard to memorize either. I used to have a thing to memorize this somewhere. Or was it in this book maybe? But in step 1, you don't really per se have a thing for electrolytes like the way we are looking at it right now. Yeah, we're not gonna find that. Okay, I'll recreate it. We'll see. Let's look at this question first. 32-year-old woman comes to the office for evaluation of intermittent dyspnea over the past several months. She has a sensation of not getting enough air and of lightheadedness during the episodes, which spontaneously resolve after several minutes. She went to the ED 2 weeks ago for similar symptoms and was discharged after normal cardiac and pulmonary evaluations. Alright, so she's having some difficulty breathing, but everything looks okay. She has no other medical conditions, takes no medications, doesn't smoke or drink, recently relocated to a new job. During the interview, she experiences a symptomatic episode in which she appears anxious and diaphoretic, takes rapid breaths. So basically we're talking about a panic attack, right? Shaking in the hands and anxiety. Blood pressure is looking high, pulse is fast, respiratory rate, oxygen saturation look okay. Physical exam, the neck veins are not distended, so there's no volume overload. Lungs are clear, heart sounds are normal, the remainder of the exam is normal. What is most likely to be observed during these episodes? And they went with this answer, an electrolyte related answer that only 35% of people picked: decreased serum ionized calcium. So most times when I'm trying to show you guys a mnemonic I created, the mnemonic is already written, which often I've had, I have a lot of people that are quote unquote haters, right? There's a lot of weird people out there that will say, oh, you're just saying that, but you don't actually remember it. So it's very important to actually remember the mnemonics you create, otherwise there's no point to the mnemonic. So I'll get to recreate it here now since I don't have it on this page, and this is a sentence version of these things, but the mnemonic for this is actually really nice, okay? So look at this case scenario, acidosis, right? So in acidosis, pH is going to be high, right? And that also is supposed to remind you that PTH is going to be high, okay? Why is that going to happen? So in these patients with pH and PTH, right, there's a lot of connection because of calcium. Directly speaking, when pH is high, calcium is high. Okay, that's one of the first things you want to see here. Ionized calcium is going to be available, a lot of calcium. What am I saying? Calcium, pH is high, PTH is high, excuse me. And pH high meaning is alkalosis, right? Actually, it always helps if you write it down. because it's very easy from lack of talking about these things a lot. pH high does not mean that you're in acidotic state. pH high is like a pH of 9, right? So alkalosis. When pH is high, PTH is high. Why? If you look at this case scenario where the pH is actually high, that's the alkalosis case. All your calcium is now stuck to, right? All the calcium is now stuck to your albumin. So theoretically speaking, in this person's serum calcium is going to look low. So PTH is high and calcium is low. The way to memorize how pH and calcium affect each other is just by remembering pH high, PTH is high. These two, just remember it like that. When is PTH ever high? PTH is only high when your calcium is low. So you memorize it like that. That's it. Same thing goes for the other case scenario. When pH is low, so that's acidosis, right? That's the case scenario of on the left side. You have a lot of H+. All the H+ is attached to albumin now. So more of the calcium is free. It's not attached to albumin anymore. Basically what H+ does, as you can see in this picture here, is it takes calcium's place on albumin, thereby allowing calcium to be free. So when pH is low, you can just write the same thing again. PTH is low, and that means that calcium is going to be high, right? In our patient in this question down here, they combined multiple things. What happened in this patient? She was going through a panic attack. Panic attack induces hyperventilation. When you have hyperventilation, right, you kind of throw off all your CO2. When you lose all your CO2, right, we're going to think of a person who's basically going to have they threw off all their CO2, they lost their acid. pH is going to be high, right? They're going to have alkalosis, right? Mainly respiratory alkalosis. So pH is high, PTH is high, calcium is low. Answer is decreased serum ionized calcium. That's it. This thing is something you can, when you get a question on this, you can recreate this for yourself on your cheat sheet, on your whatever paper. You don't need to memorize this like on a cheat sheet kind of thing. This is something that you memorize directly, which is the only time mnemonics are actually good, right? So I recreated it right here in front of you guys, right? This way you remember everything. You would always also get this question right too, because that's the more common question. They'll give you a weird question about pH and all this other drama, and then they'll ask you what's going to happen to PTH. So now that's also in this mnemonic. If you get a question where they're trying to ask you about PTH, which I think might be this next one. But generally speaking, great mnemonic to get these kinds of third-degree questions correct. The question was about panic disorder. You understood that the patient would have respiratory acidosis from breathing too quick. Acidosis is this bottom case. Sorry, respiratory alkalosis from breathing too quick because they offload all their CO2. Alkalosis is the upper case, right? pH is going to be high, PTH is also going to be high, calcium is going to be low, and that's the correct answer. There was no reason for anyone to get anything else in this question. Like, why would you pick decreased serum bicarbonate? Once you figure out the person is hyperventilating, as long as you can keep your mind straight, when you're hyperventilating, you're breathing fast. You offload all your CO2. So if you offload all your CO2, you become somebody who has no more acid, so you become alkalotic. And that's going to be a respiratory alkalosis because the main problem here is breathing too quickly. And respiratory issues also take a long time to be compensated for, right? But if you have a person with respiratory alkalosis from breathing too quickly, decreased serum bicarbonate is something that is not going to show up during these episodes. Remember, compensation takes a while, right? The compensation for respiratory problems takes a while because metabolic compensation is not something you can control. You can't just close your eyes and focus really hard and then get your kidneys to stop throwing away bicarb or make them throw away bicarb harder. You can't do that. It takes time for all that to happen. But when you have a metabolic problem, respiratory compensation is very easy. You can easily just control how quickly or how slow you're going to breathe to compensate for the metabolic problem. Right, so this was a trick answer choice. The question directly asked you, what are you going to see during the episode? During the episode, you're not going to see compensation. During the episode, you're going to see a person with respiratory alkalosis, where because of all the alkalosis, free calcium is going to become very low. All the calcium is going to get stuck to albumin. Right, so that's what they're describing here. This is a really nice diagram to show you some calcium homeostasis stuff. Nothing crazy. This is a very straightforward question on familial hypocalciuric hypercalcemia. The name of the disease tells you exactly what you would find in the patient, and once you see that in the patient, you should always pick that answer choice. Normally, hypercalcemia should have hypercalciuria. If you have a lot of calcium in you, you should be urinating calcium. But in these patients, they don't have a good calcium sensing receptor, so they don't think they have a lot of calcium. Their body doesn't recognize they have a lot of calcium. So on labs, we can see that they have a lot of calcium, but their body acts as if they're low on calcium, so they don't urinate a lot of it, and that's all that's wrong with them. Theoretically speaking, they should have absolutely no symptoms, which is why this patient is showing up just for basic pre-employment screening blood tests, but no symptoms, no constipation, no nothing. And the last topic here is just hypomagnesemia, which is literally nothing to talk about. Very straightforward and easy topic. So yeah, I'm just gonna stop here, and then in our next topic we'll move into acid-base disorders and make this perfectly easy. This video that I'll make on the acid-base disorders is going to be the same video I'll use for step 1 as well, because I'm going to be teaching it from the step 1 book. In CK, they don't really have too much about it. I moved this, it's the same diagram. I moved all the same notes into here, and then a bunch of the same practice questions, because, and most of these practice questions are CK practice questions, so we'll look at these practice questions rather than step 1 questions, and we'll have it all down pretty well. There's a lot to know. There's a lot to know with these acid-based things, but these questions, you can see how many things there are you can get questions on, right? A lot of shit you can get questions on. Each one of these is a question of its own. But this topic is massive, very important to know, because you can get, you're obviously going to get a question on this airway obstruction, COPD. You're going to get a question on acute lung disease, right? You're going to get a question on opioid overdose. You're definitely going to get a question on somebody who maybe had alcohol poisoning, right? Methanol, iron tablet poisoning, diabetic ketoacidosis. You're going to get a question with someone with diarrhea, someone who's taking spironolactone. You're going to get a question on all these topics on your step. So you should know all of them and exactly what's going to happen in terms of acid-based derangements, right? So we're going to make sure we can logically understand exactly how each of these is supposed to be evaluated and what you're going to find compared to normal. And we'll do that in the next session.